And want to stay on time. So if those of you could take a seat where you're going to be seated. We have three speakers this afternoon on internal medicine. The first one is on heart failure. And I'm pleased to introduce Dr. Dale Renlund. Many of you may know of him. He's from Salt Lake City, trained at the University of Utah, and then for his fellowship and additional training, he went to Baltimore. And then came back to Utah, has been a real resource here in the Intermountain West, has been medical director of the transplant unit, and obviously a lot of his papers have dealt with transplant rejection issues and what to use medication-wise. His recent interests have evolved around treatment of heart failure, both for medical treatment of heart failure as well as device therapy for heart failure. So certainly a wealth of information over the last years. The other thing that I just found out while I was talking to him before the lecture, and I didn't realize this, but he has a calling and will be heading to South Africa very shortly, and said to me that this may be the last medical lecture that he gives. So with that introduction, please welcome Dr. Dale Renlund.
Thank you. I'd like to talk about the management of heart failure, and specifically as it relates to what most of us would see in a general medical practice, and that includes a significant proportion of that which we call diastolic dysfunction. I have some disclosures that are there, and it shouldn't influence what I say. Heart failure is the most common cause of hospital admission in patients over age 65. And a common theme that we'll see is it's almost, if you take a step back, it's almost a disease of aging, and that the prevalence increases with age. It accounts for more than 1 million hospitalizations per year, more than 6 million hospital days per year, $12 billion in costs annually in the United States. Rehospitalization or death happens in approximately 50% of people within 6 months of the hospitalization. Median length of stay just short of a week, and in-hospital mortality is significant. It's probably a little lower than this, as we'll see, but it's still a significant issue. 70% of all those that you admit to the hospital, 70% they have a chronic, they already have the diagnosis, and they come in with worsening of their heart failure, their chronic heart failure. 25% it's the first onset of heart failure, and 5% are the frequent flyers that I frequently see who have really refractory to therapy, and this is the group that ends up going on to fancy things such as heart transplant, left ventricular assist devices, or the vast majority, it really is an end-of-life strategy, and there's nothing much to do except to palliate. Of those that are admitted, it's interesting that almost 50% have really preserved systolic function, and that's something we'll talk about here in just a moment. But it's very common that you look and the systolic function is quite normal, and the problem is one of diastole, and we'll talk about that, and it's something that is quite crystal clear over the years that that's a significant proportion of what we see. If you look at heart muscle problems in the United States, more than 90% of them are accounted for by these things. So you could look in a textbook and you can see hundreds of different etiologies for heart failure, but really it's grouped in these: coronary disease, hypertension, valvular disease, alcohol or other toxins, chemotherapeutic agents, methamphetamine, cocaine, things like that. And then this group that the patients refer to as, when I tell them they have an idiopathic cardiomyopathy, they say that means that the doctor's an idiot and doesn't know what's going on, and that's about true. It turns out that probably 20% or more have a clear genetic or familial basis to it. And I suspect when this chapter is all written, we'll find that most of what we call idiopathic dilated cardiomyopathy there's a genetic predisposition to it, and then some environmental trigger that causes the sequence of events to occur. If you look at, here we see on this slide, this is per 100,000 people, but if you look at the down on these here, so this is men who are discharged from the hospital with their first diagnosis, of the diagnoses listed at hospital discharge, and we look at the men in red, that with it listed as the primary or first diagnosis, that's been steadily increasing from 79 to 2004. And a similar story is seen with the women. When you have heart failure listed as the first diagnosis or the primary diagnosis, there's been this steady increase in incidence. But if you look at the number of times, this is where it's listed, and again, if we just look at the men in the green triangles, this is where heart failure is listed as the second or subsequent diagnosis. And what that suggests is that the number of times that heart failure is seen as a comorbidity of what's going on, prompting the hospitalization, is increasing even faster than the rate of heart failure admissions for a primary diagnosis of heart failure. And this is shown in this slide. We looked in this registry study, you look at people with heart failure that are admitted to the hospital and look at the comorbidities that they have. So about a fifth have anemia there. About a third have some atrial arrhythmia going on. If you look over, 40% have diabetes going on. If you look at everything with chronic renal insufficiency, and we'll hear from a wonderful nephrologist in the next hour, but if you look at those with heart failure admitted either with chronic dialysis, acute renal failure, or chronic renal insufficiency, we're talking over a quarter of the patients that are admitted with heart failure. That's part of what's going on. So that as someone's admitted with heart failure, the typical patient has a number of comorbidities, and sometimes it gets in the way of doing what the heart failure doctor would want to do. From a heart-lung perspective, dry is good. From a kidney perspective, wet or a little bit wet is better. So what we need to do always is to optimize the cardiac output and try to make things work out. This again carries on the story about, if you look down here, let's look at the women less than 65 years of age, and they're admitted for heart failure. And as you can see on this scale, it's a trend that's clearly going up. It's increasing somewhat. But if you look at here, again, women over 74 years of age, the frequency of hospitalization is going dramatically higher. Again, the older we are, the more likely we are to have heart failure as a diagnosis. That's what that is saying to us. What this slide shows is it shows the number of patients who are hospitalized for heart failure, and it looks at their left ventricular ejection fraction. A normal left ventricular ejection fraction, and that's simply the percent of blood squeezed out of the left ventricle per stroke. Normal would be 55 to 60%, depending on the technique. And of all these patients that are admitted with heart failure, 42% have an ejection fraction greater than 40%. And if you look down here where the left ventricular ejection fraction is, these folks from here all the way to here have ejection fractions over 50. The reason for this, interesting that 42% have an ejection fraction greater than 40%, all of these folks would have been excluded from virtually every heart failure clinical trial that has ever been done. Almost. The vast majority of people have been studied in these heart failure medication trials have had ejection fractions less than 40. So all the trials with ACE inhibitors, ARBs, beta blockers, and so on, spironolactone, all of them have been done in essence in people that don't cover this 42% of people. So a question, and this, we won't tally this, but just ask yourself this and see which one you would say. Here, this heart failure with preserved systolic function. Which of these is true? Heart failure with preserved systolic function has a worse prognosis than heart failure with systolic dysfunction. So again, systolic dysfunction, easy to think about. The heart does not vigorously squeeze, and we measure it as an ejection fraction. So And the problem, in essence, the simplistic way of heart failure with preserved function is the heart squeezes okay, but it really is stiff and has trouble relaxing. That's the easy way. Just think of when you try to blow up a very flexible balloon. It takes very little pressure and it just fills nicely. A stiff balloon takes quite a bit more pressure, and that's what this really is. So does it have a worse prognosis than the systolic dysfunction? Is it common? Does it present differently than heart failure with systolic dysfunction? One can differentiate between heart failure with preserved function and heart failure with systolic dysfunction based on assessment of neurohormonal activation. Or among patients that are hospitalized for heart failure, those with the preserved systolic function have a shorter length of stay and are discharged in better shape. The only one there that's correct is this one, that heart failure with preserved systolic function is common. So if you look here, these are folks admitted with heart failure, and so we're talking a registry with 40,000 in it. These are patients with preserved systolic function. These are those with the low ejection fractions. And if you look at this, there's no difference. And if you look at p-values, you can say, okay, I'm going to see where there's a difference to see if I can differentiate clinically between these groups. Well, even though this is significant, the difference between 65% and 63% is such that it has no clinical significance at all. And you go down through these, and even jugular venous distension, a third versus a quarter, doesn't really help me clinically. And the bottom line of all of this here is to tell you that despite everything that we think we're good at examining, just looking at them and talking to them, you cannot differentiate between those who present with preserved systolic function and those who have systolic dysfunction. You might say, well, look here, there's a near doubling of this B-type natriuretic peptide. And it's true that it's much higher in those with systolic dysfunction. But I can tell you there are a lot of folks admitted with heart failure with systolic dysfunction who have BNPs that are 500 or so. So I don't think that helps you either. And look at the difference in creatinine. That's not meaningful. And the serum hemoglobin likewise isn't meaningful. The point of that slide is by talking to them and examining them, you can't tell the difference between the two. You need something else. If you look at outcomes, you see that those that have, and here in the red, those with preserved functions, these are those with heart failure with preserved systolic function, and the lighter pink are those that have systolic dysfunction or poopy hearts. The length of stay is really no different, whether in mean days or median days. In-hospital mortality is different, 3% versus 4%. But again, if this mortality rate of those that have systolic dysfunction being 4% versus 3% is not all that different. The mortality rate in hospital remains high. The survival, if you look at those, again here the dotted line are those with poopy hearts, the systolic dysfunction, is virtually identical. They live the same. They survive the same. What we've recently found out is that while they live the same way, those that have no systolic dysfunctions, those with preserved function, they die differently. Those with preserved function are dying of their comorbidities, more so than those that have systolic dysfunction. So the systolic dysfunction, many of them are dying with arrhythmias, progressive pump failure, embolic things going on. Those that have no systolic dysfunction are dying more of their comorbidity, their renal failure, their pulmonary disease, and things like that. If you look at an idealized pressure volume loop, so here you're finished squeezing down here at D, and this is going to be brief, it's not so painful. But as the heart starts to fill, it fills until you start systole. Systole causes the pressure to go up. Then here the aortic valve opens, the ventricle empties, and now you start with the aortic valve closure, pressure drops down, and then you start this filling. All of the action in this preserved systolic function, the problem is right here. with the left ventricular filling. So if you look here, and again, just focus over here on the diastolic dysfunction, a normal person, as you increase the volume inside the ventricle, the pressure doesn't go up until the ventricle is fairly well filled. But look at the patient that has diastolic dysfunction. As you start to fill the ventricle, then the filling pressure increases much more dramatically. That's the fundamental problem with this. And you can see it in different ways. And just if you look at an echo and you look at the Doppler velocity at the mitral valve, initially, actually, if you take just a peek at me, if my eyes are in the left atrium and my fingers here are the mitral valve, initially in a normal ventricle, as the mitral valve opens and blood flows from left atrium into left ventricle, that's where most of the filling is taking place, in essence. And so this first wave here, the E wave here, is high. That's where most of the filling happens. And so it goes like this. The valves open, a lot of filling occurs, the valves drift shut, and then with atrial systole, they pop open again for some filling. And so this would be normal. As the heart gets stiffer, it's almost like you become more dependent on that atrial kick. And now you have the filling is slower, it doesn't reach the same peak, and then you get atrial kick, and you get to this E to A reversal. But in essence, the way to think about heart failure with preserved systolic function, the heart is stiff. It's like a thick balloon that you're trying to blow open, and it has trouble filling. That's the fundamental problem here, and it's manifest in many different ways in the pressure volume loop and in the echo recordings. The differential diagnosis of heart failure with preserved systolic function is that you can have something that is called diastolic heart failure, or it could be as a result of hypertension, a restrictive issue or an infiltrative issue such as amyloidosis, hypertrophic cardiomyopathy, non-compaction of the LV. You can have the LV working fine, but if you have right heart failure, for instance, due to pulmonary hypertension, it's going to look like you've got everything okay, but the problem's on the wrong side. It's on the right side of the heart. So pulmonary hypertension, RV infarct, arrhythmogenic RV dysplasia, and these other things. But the bottom line is that when you look at an echo, the LV is squeezing just fine, and they still have signs and symptoms of heart failure. And how you treat it, you treat somebody very differently if they've had an RV infarct versus whether they have diastolic dysfunction. So in heart failure with preserved systolic function, and these are out of the guidelines, the ACCHA, Heart Failure Society of American guidelines, and the goal is with this is to make it so they're not congested, get rid of the congestion. Because they're so dependent upon atrial kick, you do everything you can to try to maintain that. Because they're dependent, their cardiac output is very dependent upon the time for cardiac filling, you do not like to have them tachycardic. And then you want to make sure that if there's coronary disease involved, that you get that as addressed as you can. And then there are things that you hope might prevent hypertrophy or promote its regression and prevent fibrosis. And so the approach, if you think of heart failure with systolic dysfunction, it's really no different than this. Sodium restriction and diuretics. To reduce the filling pressure, sometimes these, especially if they're hypertensive, those might be good agents to try and use. The cardioversion, antiarrhythmics, and nowadays atrial fibrillation ablation can be used to deal with atrial fibrillation. Beta blockers, calcium blockers to slow things down, and even at times, some of the patients that have refractory AFib and they've got diastolic dysfunction, and you use all the slowing drugs that you can, and it just flat out doesn't slow them down enough, the EP guys can ablate the AV node, and let's say they can't do an AFib ablation, they can ablate the AV node and let the patient be dependent on a ventricular pacer. And they'll actually do much, 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 much better. So this can be something that's used. And then make sure you're not dealing with anything that you can fix, such as coronary artery disease. And then there's some data that suggests that aldosterone antagonists might be helpful. There's an ongoing clinical trial that is sponsored by the NIH that's looking at PDE5 inhibitor like sildenafil to try to help with this too. As you think about a classification of heart failure, most everyone's familiar with this New York Heart Association classification. If you go from mild symptoms to severe, it goes from 1 to 4. And I can present, say, with new onset heart failure and have class 3 symptoms. And you take care of me, tune me up, I can go to mild symptoms. Then I have a crab and Frito overdose and I can go back to moderate symptoms. And I can bounce back and forth because this is just based on my symptoms. A helpful adjunct now is a staging system that goes from A, B, C, and D. Here, you simply progress badly from A, B, C, and D. A is just those that are at high risk for developing heart failure, so those that have hypertension. One of the saddest things is that about a third of the folks that we end up listing for transplant have a burned out hypertensive cardiomyopathy. And what that means is that if they had been diagnosed earlier, if they had been treated to goal, they likely wouldn't have ended up where they are. So that thinking of what do you do with stage A? Well, you make sure it doesn't progress to stage B. Stage B, there's structural disease, but the patient is not and has not been symptomatic. Stage C is what we typically think of. They have structural disease, and they have a history of being symptomatic or are presently symptomatic. So again, once you've developed structural disease, you don't revert back. This is just two arrows going the same way. If stage C progresses and ends up with refractory heart failure, then this is where the choices are very limited. Transplant, which is still a terrific thing and is wonderful for those that get it done. Permanent left ventricular assist devices, which is an emerging therapy that is helpful in some, but the vast majority, these that are stage D, end up with a lot of futile care going on with nothing that is of great benefit to them, except trying to figure out how to ease them out of this life with the least amount of pain and suffering. What's interesting is that the way this all progresses is that pathophysiologically, and the cardiologists here and even the internists here have seen folks that had basically a mild MI, and their ejection fraction is, say, 40, and they're doing fine, and then without a new insult, sometime later, they have an ejection fraction that's in the toilet and is an ejection fraction of 20. And what's happened is that initial insult causes dysfunction that activates the neurohormonal systems, and that leads to altered gene expression. The myosin heavy chain reverts to a fetal form, and then there's apoptosis. The myosin heavy chain, okay, typically as adults we have an adult form of that myosin heavy chain. In response to neurohormonal activation, it changes back to a fetal form that's a slower twitch, and that's part of the problem. And this is the mechanism by which beta blockers help in heart failure. But that's what happens. That in turn leads to this remodeling. As you can see on this side, you go from an American football shape to a rugby ball shape to basketball shape. All this is adverse remodeling that in turn leads to worsened function, more neurohormonal activation, more badness, and this just spirals down until you get to stage D things where you have these limited choices. That's the pathophysiology that occurs. The drugs that we use try to interrupt that and slow it or flatten this curve from being downhill. But if you think about it with these different stages, there are things that are so totally appropriate. So in stage A, and again, they don't have heart failure, they're just at risk for heart failure. You do these things that you see down here, treating the hypertension, knocking off the smoking, you treat their lipids, you get them to exercise, and so on. Stage B, again, that's structural heart disease but no symptoms. There are certain things that might be appropriate in that group. But if you get to stage C, for instance, now ACE inhibitors, there is no question about it, ACE inhibitors are indicated for folks with heart failure, with systolic dysfunction. No question about it. So if they're not on it, it's an error. If they don't tolerate an ACE inhibitor because of a cough, they should be on an ARB. There should be a trial of beta blockers, totally appropriate, and again, the evidence base for this is overwhelming. In African Americans, the combination of isosorbide nitrate and hydralazine can be appropriate as an adjunct to those. And then, of course, diuretics to get them to a non-congested state. ACE inhibitors, ARBs, beta blockers have clearly shown survival benefit. No question about it. Spironolactone in people who have an ejection fraction less than 35%, creatinine less than 2.5, and potassium less than 5, and class 3 symptoms as they enrolled, clearly shows benefit as well. Digitalis has never shown a survival benefit, but can help people symptomatically at times. And then a whole issue with ICDs and biv pacing that we'll talk about. Stage D, we'll talk about in a bit, but really the choices are quite narrow there. So here's a case that is very typical. It happened probably a month or so ago. 37-year-old man admitted with new onset heart failure. His echo shows an EF less than 20%, again normal 55 to 60. 4-chamber enlargement suggesting that this is not an acute issue, it's a chronic issue. There's been time to remodel. He has mild AV valve regurg. Blood pressure is 142/88. He's got lots of right-sided failure too with the JVP to the angle of the jaw. He's got lots of edema, but he's well perfused. He gets IV furosemide at a good clip, and a long-acting ACE inhibitor is prescribed. He has some coronary disease based on a cath, and nothing else to suggest this is anything but an idiopathic cardiomyopathy. He diureses 12 kilos over 4 days, and the house staff just ratchet up his lisinopril because he's hypertensive, tolerating it just fine. He's discharged on furosemide 40 a day, lisinopril at real good dose 20 a day, and as he's walking out the door, he started on carvedilol 3.125 twice a day. He shows up in our clinic 4 days later, and he's had 3 days of lightheadedness, no orthopnea or P&D, blood pressure 78/60, heart rate 110, jugular venous pressure flat, no edema, serum creatinine has bumped from 1.4 to 2.2. What's wrong here? And here's the little principle, is that as somebody comes in with lots of fluid on board, their renin-angiotensin system, their sympathetic nervous system is really revved up. They will tolerate lots of ACE inhibitor. However, once you get them dry, or more appropriate, euvolemic, now their renin-angiotensin system and their sympathetic nervous system is less revved up, and they will frankly tolerate less. And so that here, a smarter move for this house staff group would have been to just get him to modest dose ACE inhibitor, dry him out, and then add the beta blocker, and then if he has, and up titrate that, and then if he has blood pressure to play with later, then go up. This is a very, very common thing that happens as people leave the hospital. He probably also was over-diuresed at this point. Once you get these other things on board, now the diuretic might be a little bit too high for him. But this is a very, very common thing. So is the ACE inhibitor indicated? Absolutely. Is it appropriate to diurese him? Absolutely. Is it appropriate to start him on a beta blocker once the volume status is okay? Absolutely. But the key is trying to get it done in the right frame, the right order, and you don't have to make a patient, perfect overnight. Once they're doing better, you can go a little more slowly, and there's no rush to get it done. Nowadays, we used to call it congestive heart failure. The preferred term now is just heart failure, because many of the patients that show up in your clinic with heart muscle dysfunction aren't congested because you've appropriately taken care of them. But when they come in with acute decompensated heart failure, then what's going on? This is the approach. You want to make the diagnosis, and you usually find it very clear. BNP, B-type natriuretic peptide, is very helpful when you're confused. So if they come to the ER and it's somebody that is breathless, if the BNP is low, they don't have heart failure. That's generally totally true. It Turns out that the chubbier we are, the less reliable the BNP is, which is surprising. The older we are, the higher the BNP, but it's not up in the real high ranges. It's more in up to 200, and women have a higher BNP than men. But in general, it's the negative predictive value of the BNP that's so helpful. If somebody's breathless or has edema in the ER and their BNP is low, it's not heart failure. Where we get into trouble with the BNP is assuming that nothing else is going on. So somebody comes in breathless, you get a BNP that's elevated. If you now use that to close your blinders and focus exclusively on heart failure, you might not recognize that they actually had a PE or they have a pneumonia that's going to kill them. So again, it's the negative predictive value where it's most helpful. And so you make the diagnosis, you try to find out why it happened, and then risk stratify them. You get rid of the congestion, you treat low output issues, you correct the abnormality, the hemodynamic abnormality, and initiate drugs that have proven long-term benefit. This teaching one is really amazing. I did publicly poo-poo this notion for many years until proven wrong. Teaching patients about what's going on with their heart failure makes a huge difference and actually impacts their survival. And a big error that frequently occurs is they're seen by a hospitalist, they're perfectly cared for, they're discharged to the outpatient setting, and their next appointment is in 6 to 8 weeks. And invariably, that's where lots of these readmissions occur. Frequently, they need to be seen much sooner than that. If I were king and had an ideal world, a discharged patient would be seen within 1 to 2 weeks after hospital discharge. And the sicker they were, the tougher they were to deal with, the sooner I'd have them seen. There are things in the guidelines that are recommended, or when you hospitalize. Clearly, if they are severely decompensated, if they have dyspnea at rest, class 4 symptoms, really hemodynamically significant arrhythmias, these things make it so that hospitalization is recommended. It should be considered when it's worsened congestion, where the weight gain is going up. Frequently, these folks have an edematous gut, and now you're going to have a hard time getting the fluid off without it being with the diuretic without giving the diuretic intravenously. And any comorbidities, if they have significant heart failure precipitated by a pneumonia, trying to deal with both as an outpatient usually doesn't lead to anything good. Some people advocate that new onset heart failure is admitted and worked up. I think that it could be considered. It depends on the quality of the outpatient care that person's going to get. There are things that precipitate acute decompensated heart failure. It was amazing in Baltimore, this many years ago, I suspect it's the same, that the day after Labor Day and the day after Memorial Day, we had lots of admissions for pulmonary edema. And it all related to salt overload. People would go out and picnic, and they'd come into the hospital, and they were very easy to treat, but it was dietary indiscretion that did it. It's surprising how often drug interactions, such as they have stable heart failure, they develop gout, and they're started on a nonsteroidal anti-inflammatory drug that promotes fluid retention. Now they're tipped into heart failure. That's quite common. And then looking for these other things, anemia and thyroid disease, you just don't want to miss things that you can actually reverse and treat. If you think of people in this situation, and won't spend a long time on this one, but most of the people they admit are in this upper quadrant here. They're well perfused. They still have good pulses. They've got good blood pressure. It's just that they're very congested. And in this quadrant, then, there are things that are very appropriate and easy. Diuretics will make them better. If the diuretics fail to work, there are other drugs that can be tried, such as Naseritide and even ultrafiltration. But most of this group does well with IV diuretics. In contrast, this group is in big trouble. If they're cold, meaning they're not well perfused, their blood pressure's low, they're cool and clammy, and they're congested. And frequently these people are going to need inotropic drugs to help them diurese, and unless it tunes up quickly, they're in trouble. And so sometimes the question to ask is, are they well perfused? And that's just how do they how do they feel and what's their blood pressure, and are they wet, and that's an assessment of their volume status. 20-year-old woman admitted with new onset heart failure. Echo shows an ejection fraction less than 20. She has 4-chamber involvement. Again, it's chronic. And her blood pressure, 92/60, elevated central venous pressure, 2+ edema, cool extremities. This is from the cardiologist's report. She started on furosemide PO and given a beta blocker. The pharmacologic effect of the beta blocker is to increase the wedge pressure and decrease the cardiac output. That's the pharmacologic effect. The biologic effect that we want is to change that myosin heavy chain. That takes weeks to months, but nonetheless he started it here. 12 hours later he reports that her blood pressure is about the same. She hasn't made a lot of urine. He records that her JVP is high, her extremities remain cool. He changes to IV diuretic and bumps her carvedilol. Then 36 hours after admission, she's got a blood pressure of 100, but the pulse pressure is quite low, only 10. She's not putting out urine. She's cool and clammy. Lasix, furosemide, is changed to 40 IV twice a day. Carvedilol increased to 12.5 twice a day, and DIG is added. 48 hours after admission, blood pressure 70, no weight change, 700 ml of urine out in the last 24. He can't see the jugular venous pressure, and she's cool and clammy. What do you think her right atrial pressure is? She comes in, and it's here. Then later, it's here. And now she hasn't urinated or anything, and he can't see it. Where do you think it is? It's here. It's gone steadily up. And what do you think her wedge pressure is? It's off the charts. That's an estimate of her left atrial pressure, and her cardiac output is low. And she was transferred to our hospital. She got biventricular, she went right to the OR, got biventricular support, came out brain dead. And the issue is that this girl needed inotropes right away. And the notion that beta blockers are helpful in heart failure, though true, it's the timing of when they're used that's important. You use them after the patient is tuned up and volume appropriate and not when they're cool and clammy and hypotensive. And that's the take-home here. She needed the opposite of a beta blocker. She needed a beta agonist. So that's a caveat on these folks. Oftentimes when they present that way, most of the time, after you tune them up and start reversing things, you can get these people better, at least for a period of time. If it goes too far, it's sad. So as they're discharged, you optimize their oral heart failure meds, ACE inhibitors, beta blockers. If they don't tolerate the ACE inhibitors, an ARB is totally appropriate. If appropriate, even an aldosterone antagonist. You try to get the comorbidities managed, and you look at the risk of sudden death. And at discharge, the Joint Commission Accreditation of Hospitals requires patient self-management instruction, assessment of LV function to have been done, ACE inhibitor or ARB use, and smoking cessation. And one of my colleagues, Dr. Kafori, took and looked at all the data that we had and looked at people who had none of these measures fulfilled and their subsequent survival versus all of them having those measures fulfilled and their subsequent survival. And if you tease this out, it's crystal clear that even teaching patients about their self-management of heart failure improves survival. That's why it should be done, not because JACO says so, but because it has an impact on their subsequent survival. So measure the EF because you really don't know whether it's systolic or diastolic dysfunction unless you do. If it's an EF less than 40, then there are appropriate medicines for them to be on, and then begin teaching self-management and make sure they don't smoke. Stage D is relatively easy to see. These are frequent, yes? Of hers? Idiopathic dilated cardiomyopathy. So there's no history of drug use, there was no coronary disease on post, and so it's just an idiopathic, there was no myocarditis. So all the things we think of is, again, we most of the time would think there's some viral trigger, a genetic predisposition that made it happen. people who have increasing symptoms, worsened blood pressure, more congestion, more frequent hospitalization, worsening renal function, anemia, these are the ones with stage D. Almost invariably they have ejection fractions that are low. And so here's a patient that was sent to us at the VA for transplant consideration. 54-year-old man, EF 24, high filling pressures, triple vessel coronary disease, inoperable. He comes in really wet, really symptomatic, and he diureses relatively simply and is sent home on a modest dose of furosemide. He comes back a week later, class 4 symptoms, CVP is again elevated. He diureses easily, and this time he's sent out a little bit more bigger dose, 1 time a day. And then 2 weeks later, he's back looking about the same. He diureses easily with IV furosemide. And then this unbelievably irritating medical student intervenes. He's like the medical student, if you see young Frankenstein at the beginning, and he asks those irritating questions. He's like that one because he took a history. And the patient was drinking about a half to a full bottle of pickle juice a day. So he was salt loading, and all we needed to do was intervene on that, and then it changed the course of this guy's heart failure, because now he wasn't volume overloaded. You could get him onto appropriate drugs and so on. So not everybody that's volume overloaded has stage D heart failure. When they have stage D, you have a choice, in a sense. And the questions to ask, are they a transplant candidate? Because if they are, and we still do in this country about 2,000 a year, heart transplants. And so people get on the list. We can bridge them through to transplant. And if they're a transplant candidate, then that's a good option for them. It's a terrific option for them. If they're not a transplant candidate, the question should be, are they a candidate for a permanent destination left ventricular assist device? And that's a less good option, but it is there. There are a lot of people that we put VADs in that have been very pleased with the quality of life and have lived longer and better than they otherwise would. If the answer to transplant is no, if the answer to permanent VAD is no, it really befalls just an end-of-life strategy. And if you talk to them, and it's a difficult conversation to start, but once you start talking, you find out that they really aren't interested in multiple readmissions and lots of flogging. So there are discussions that are needed. We've done lots of transplants here in Utah and have done very well with the survivals and so on. And there are indications, and it should be in the syllabus, that have the indications for transplant. And again, survivals are good. And the workup is just as you would imagine, making sure there's nothing else that's going to be a surprise. And they're just things that we do to just check these things out. And the risk factors, the things that mean badness after transplant, is if they have significant pulmonary hypertension, which it's not intuitive, but a new right heart is not used to seeing high pulmonary pressures. And so if you put it into a high pulmonary pressure circuit, it immediately fails. And so in the old days, we used to lose people because of ignoring this. And things that make sense, they shouldn't be infected because you're going to suppress their immune system. If they've got other organs that are bad, and so on. These are just, in terms of extremes of age, I had a colleague a little while ago who we said the person had an alcohol problem if they drank more than Jack. So, and on some of these, I don't know if we have obesity there, but if they're more obese than I am, that's a worry. So, so we set things. But the extremes of age, we've transplanted as old, not that it's extreme, but as old as 72, 73 years of age, done very well with that. But typically those folks would have no other comorbidity. So heart transplantation is standard of care for some, and improvements continue. Permanent replacement with artificial hearts remains experimental, but we use artificial total hearts to bridge people to transplant. We use VADs, left ventricular assist devices to bridge to transplant or for permanent destination therapy. The way these left ventricular assist devices work, here's the first generation of those. It was a HeartMate 1. where this hose is basically put in the LV apex. The hose with a valve in it right there goes to a pump, and then it's pumped out into the ascending aorta. These things, unfortunately, lasted about 18 to 24 months, so it was a very long run for a short slide. The smaller HeartMate 2 version and others like it are much smaller and much more durable and are doing better with that. And you can, let me just point out, you can take and look at, you can take these patients with, if they're really extremely bad shape, then they're going to do very poorly. If they're in pretty good shape going into this, then the outcomes can be quite acceptable. And so they're the appropriate thing for some people, but certainly not everyone. The third component, the end-of-life thing, it's important to look at their expectations. And so if somebody is in denial about what's going on, and I can't read this, but unrealistic expectations, then they have unfulfilled wishes, they'll have despair and discontentment. On the other hand, if one can get them to accept the situation and have realistic expectations, and then they'll fulfilled wishes and they're at peace, there's some contentment. So there's a Talmudic scholar who wrote in 900 years ago, "Who is rich? He who is content with what he has." It's trying to get the person to understand where they are and what can be done. Or as my wife said in 1977 and every year since, "Do you know how I stay happy with my husband? I maintain low expectations." The course of heart failure then can start with the onset of heart failure. Most people, in response to appropriate things, appropriate workup, and the use of these things, helps people get to a plateau that's much better than where they started. This plateau can be indefinite. After some period of time, some patients start having an exacerbation or two, and every time they do this, you rarely get them totally back to where they were. And after they do this a few times, you know that this trajectory is downhill, and now you know you're dealing with stage D heart failure. And now you try to assess the prognosis and use whatever you can. The things in blue, excuse me, are supportive care measures that need to be there all the time. And early on, they need a lot of blue stuff. They need a lot of teaching. Later on in this plateau phase, they don't need so much, but as they start having exacerbations, and especially at the end, as they're going downhill, there's a lot of support that can be given. The patients will feel better even though you're not doing a lot, but just helping them. The story on defibrillators, here's the story. There's not a slide on it, but here's the story. If I have an ejection fraction less than 35%, if after being tuned up on appropriate medicines, so appropriate medicines, everything done right, if my ejection fraction is less than 35%, I have a 2% per year risk of sudden death. That risk can go to near zero with a defibrillator. That's the issue. So that's why Vice President Dick Cheney has a defibrillator in. And some people listen to that and they say, well, that's not that great of a risk. Why should I do that? And the defibrillator going in is going to be about $30,000. But it's a reducible, unlike the days of Osler, where treatments were ineffective but cheap. Nowadays, treatments are effective and expensive. So a defibrillator in the right person is appropriate, and so that's clinically indicated. The biventricular pacers that you hear about, here's the story on them. If I have an ejection fraction less than 35, and if I have, say, a left bundle branch block, it's very possible, my hands are now my left ventricle, it's very possible then that the electrical impulse starts here and goes slowly throughout the ventricle. So as I start to squeeze here, this side is relaxing, and by the time the depolarization gets over to this other side and starts squeezing, this side is ready to relax. That's what's called dyssynchrony. It's like this. And so a smart friend of mine from Baltimore, David Cass, said, why don't we put a pacer here and a pacer here, a biventricular pacer, but it's really intended to synchronize the squeeze of the left ventricle. So even if I'm only squeezing 30%, I'm doing it at the same time, and that has benefit with it. It turns out that that will improve survival as well, even in the absence of a defibrillator. If you combine the defibrillator and the biventricular pacer, the resynchronization therapy, then that's the best. That combo is in the $50,000 to $60,000 range. So there is that. So 64-year-old previously healthy man, hospitalized on a Saturday evening, EF 24. He gets cathed on the next day because the cath lab was open. He has normal arteries, left bundle branch block, and this measure of dysynchrony is there. He started on medicines that are appropriate. Monday morning, he gets a biventricular, a BIV-ICD placed, and then he's discharged. 2 weeks later, he comes to see me, and he's on the same meds he went home on, and he looks great, and I ask him to increase his carvedilol. And he became unbelievably angry because when he went home, he got a 30-day supply of medicines. He intuited that this defibrillator thing would take care of it, and he'd just take the meds for a month and then be done with it. And he had just the day before he came to see me gotten his bill, and it was $76,000. What's the error here? Now, I didn't hear that, but here's the error. The error is that this guy, when he got put on appropriate medicines and appropriately up-titrated on his beta blocker, his ejection fraction went to 42. There was no indication for the defibrillator, no indication for the BIV pacer. The trials, when we did them, both for Medtronic and for Guidant and Boston Scientific, patients were tuned up and then met enrollment criteria, having an EF less than 35 then. So that's what's wrong here with this one. Plus, not teaching him appropriately about what to expect. So the current thing, we prefer to use the term heart failure instead of congestive heart failure. If you'd asked me 10 years ago what proportion of our patients have sleep-disordered breathing, I'd have told you maybe 1 to 5% max. It's probably 40 to 50% of heart failure patients have sleep apnea or sleep-disordered breathing, and it makes a difference in terms of how well they feel. It can be both. So we even have skinny people that have it. But we're tipped off more in those that are snoring and chubby. But if somebody has an improvement in ejection fraction and they're still feeling fatigued, that's one of the first questions I try to find out about, because they may not be getting a good night's sleep. The beta blockers that are out there that have survival benefit definitely are carvedilol, metoprolol succinate, which is the long-acting, and bisoprolol. Using aldosterone antagonists, just be careful. When the first trials of the spironolactone, so Rawls trial was first done, smart residents at the VA started people on the spironolactone with the follow-up in 6 months. And guess what happened? Hyperkalemic issues. So there's some caution with those. The dysynchrony, if their EF is less than 35, it's indicated, and ICDs to prevent sudden death, and then transplant or VAD if the one-year mortality, if you think it's less than, if the mortality is greater than 50%, and the end-of-life issues and discussions when appropriate. Thank you very much. Any questions? Yeah. So the question is, how does spironolactone benefit congestive heart failure? It's a weak diuretic. It probably keeps the potassium up, and to that extent could reduce sudden death. But it theoretically has also antifibrotic properties, and probably affects the intracellular matrix and other issues there. So if the best trial to read on that one is called the Rawls trial, RALES, and then there's a subsequent one that used a drug called eplerenone as well that looked at that. Yes? The question is the use of digoxin for diastolic dysfunction. I think if I were to say categorically, it would have no role except if the patient's in AFib to try to slow him down. We have no data that would say that a person with diastolic, so preserved EF but heart failure, that the DIG would make a difference in how they do. I know of no clinical trials in that. Thank you very much.
It certainly is a privilege to have somebody with as much clinical experience and insight as Dr. Renlund. Really appreciate a complex topic that I think was summarized very well, and appreciate what you've done and wish you the best in the future years. Let's take a couple-minute break just to stand and stretch, and we'll be right on to the next talk. I think we're ready to start the second session if you guys can take your seats. Our second lecture this afternoon in the medical lecture series is on nephrology. Our speaker this afternoon, Dr. Cohen, is actually a native of Delaware and went to the University of Delaware in the early 70s. And then did some graduate work both at Bowman Gray in Wake Forest, and then headed up to the frozen tundra near and dear to me, Rochester, Minnesota, in the Mayo Clinic. Did his PhD in physiology in the late 70s at Mayo. Vacated, headed south to Florida for his MD degree for a couple of years, and then migrated to the West. Went to Barnes-Jewish for his internship in St. Louis, and then was on completed his training in nephrology at WashU in St. Louis, and then stayed on there until 1990, when he migrated here to Salt Lake City. Since that time, he was in the Department of Medicine. By '99, he was chair of the nephrology department at the university. As I look through his CV, he's got an incredible number of published papers, also been recognized by the residents and by the fellows and so forth with different teaching awards through the years. He's involved administratively with the university on P4P programs. He's involved with graduate medical education. As you may know, they're trying to reformat the medical education at the university. He's only the chair of that committee. He's only the chair nationally of the nephrology societies. It certainly is an honor to have him here in Ogden, Utah this afternoon. Please welcome Dr. Cohen.
Well, thanks very much for the nice introduction. I appreciate being invited to speak to you. I do have one apology to make. I am a Macintosh diehard user, and so in making this, some of the pictures didn't translate. So what I'm going to say periodically, I'm going to tell you what's on the slide, and you're just going to have to take my word for it. It was supposed to be a picture of a urine sample here, but I guess we can live without seeing that. I'm going to speak about evaluation of patients with hematuria and proteinuria, and I'm going to try and make it relevant to what somebody who is a general practitioner, an internist, OBGYN, pediatrician needs to know in terms of dealing with these patients and when to refer them to urology or nephrology. And again, this is informal, so please feel free to interrupt me at any time during my talk. Okay, there's my disclaimer. So we'll start off with hematuria and start off with screening for hematuria. First off, you can occasionally see red cells in the urine. It's actually normal, but it should be less than 2. And if you think about that, just a drop of urine is usually about 10 microliters that we put on a microscope slide. So if you see even 1 red cell per high-powered field, it actually translates, if you do the math, to somewhere between 100,000 to 2 million red cells we lose in the urine a day. So it's actually quite normal to have some red cells, but we shouldn't normally see very many. And the other thing is the dipstick should always be negative. A positive urine dipstick always indicates pathology. Okay, so let's see if I can read these from here. Asymptomatic hematuria is, as you might imagine, is asymptomatic, and it means you don't see it and you don't have any symptoms associated with it. There was a study done looking at, 170,000 patients, and interestingly, 3% of men had asymptomatic hematuria. So this is a huge number of people, and the question gets at, should we be working up all men? Women even had a much greater incidence. 6 to 11% of women had asymptomatic hematuria. This was just in the general population, no pre-selection. I think an important point is that asymptomatic hematuria is present in menstruating women, and it's present even when they're not on their period. in increased incidence. Second point is that recurrent asymptomatic hematuria can happen up in the 4% of people who have it, so quite common. And the final point is that less than 1% of people who have asymptomatic hematuria wind up developing serious disease. So, should we screen for it? Well, there's a big debate about this. I'm going to tell you right up front, we don't absolutely know, but I'm going to give you my opinion about what I think we should do. First off, the incidence of urinary tract cancer increases after the age of 40. And if you look at a graph, it goes sort of like 20, 30, 40, it starts taking off, and then when you get to 60, it goes up exponentially. But anyway, in 2008, the United States Preventative Service Task Force guidelines came out, and they recommended against routine screening for bladder cancer. So that means don't be routinely doing dipsticks. Now I'm going to tell you that, but I'm going to bet that most people at some point are going to have a patient come in, a new patient, and whether you order it or not, they're going to get a urine dipstick, and then you're going to wonder, what am I going to do with the result now that I have it? Which is the reality. But if I could make a perfect world, I wouldn't be routinely checking dipsticks. Anyway, the USPSTF didn't comment on upper tract cancer. They just talked about bladder cancer. They said that bladder cancer is very heterogeneous. It represents a variety of conditions, of which most are not life-threatening. The second thing is that screening tests, such as urinalysis or urine dipstick, can detect bladder cancer that would be clinically unapparent, okay? But in general, the positive predictive value of this is very, very low. So they don't recommend against doing it. And in the same year, the American Cancer Society came out and also did not recommend routine screening for urinary tract malignancy. Okay, so what do we do? Now, this is where I told you that Mac and PC don't always agree with one another. And so you'll have to take my word for the data. I wanted to actually show you data so you didn't think I was making this all up. But now you can't see it. And the bottom line is that even though they're guidelines, I don't know how the rest of you are, but I'm always suspicious of guidelines, because I think guidelines are made in general by very well-meaning people, but they're asked to deliver guidelines. And sometimes the evidence for this isn't very strong. So I actually tried to look up the evidence myself, and the bottom line from this is I agree with the guidelines. Okay? Let's skip over that one. That didn't work. So, should we screen for hematuria? Well, first off, we know that urinary tract cancer is common, particularly in men and particularly as you get older. We also know that all tests have a low predictive value for urinary tract cancer. So if you have hematuria, it's more likely it's due to something else other than cancer. So for now, routine screening of patients who do not have a high risk for urinary tract disease is probably not justified, certainly on an economic basis. Now, high-risk populations should be screened. So who are the high-risk populations? First, anybody with a suspected renal disease. So a patient, let's say, who has systemic lupus. It makes sense to be routinely looking at the urine. Somebody that has an family history of some inherited renal disease. Those things all make sense. Diseases that are associated with urinary tract malignancy. And symptomatic patients, obviously, we want to evaluate. So, what are the best way to go about looking for hematuria? So we'll talk about some laboratory tests here. The dipstick is pretty good. It has a specificity of here up to 90%. It does detect myoglobin and hemoglobin, but it detects, and this is an important point, only down to about 5 red cells per high-powered field. And you can have less red cells than that in your urine and still have malignancy. But nonetheless, this is probably a reasonable screening. A positive dipstick for hematuria in the absence of red cells on microscopy may still indicate significant disease. So that's an important take-home point. If you get a positive dipstick and then you send the urine off and you don't see any red cells coming back as being present, it doesn't mean that there's no pathology. Particularly if the urine sits around for a while, if it's very dilute, the red cells lyse, they don't see anything when they spin it down. Okay, microscopy. Now, we always see this. It's best to get a first morning void. I don't know about you, but I have a hard time getting any patients in at 8 in the morning, and they've usually already urinated by then, so it's a difficult one to do. Red cells lyse in the urine, particularly if it's dilute or very alkaline, so the urine can't be sitting around very long. At our clinic, we send the urine off for analysis never. We look at it ourselves. So the best thing to do is if you do get a urine sample, send it off right away. We used to say take a little bit of salt and drop it in there, not to improve the flavor, but just to make it so that if it's dilute, it didn't lyse. Anyway, dysmorphic red cells usually indicate glomerular bleeding. It is an important discriminatory tool. I'd be very curious to know if anybody here has ever received a result from the lab that said dysmorphic red cells. Yeah, it never happens. So unfortunately, while this is a very valuable clue, it's something we need to teach our labs to look for, and it's certainly something that nephrologists do in clinic. So what am I talking about? Well, these are sort of monomorphic red cells. You can see they're homogeneous size and shape, nice and rounded, and these are dysmorphic red cells. So why do they get dysmorphic? Well, the idea, or at least as we imagine it, is that they are squeezed through the glomerulus. And somehow, in going through the glomerulus, they get distorted, disrupted, and so you get all these different size and shape red blood cells. So it is strongly suggestive of glomerular bleeding. It's not absolutely pathognomonic. Now, just a couple of other points while we're on urine analysis. If you get these results back from the lab, I thought I'd briefly go through what they meant. Hyaline casts are nonspecific, but if you see a lot of them, it suggests renal disease, and this is what a hyaline cast looks like. Granular casts, particularly if they're pigmented like this, usually mean ATN or acute kidney injury. If you have a lot of these granular casts, actually even any of them in the urine, it's abnormal. So if you get a lab back, it says a granular cast, they've got kidney disease of some sort, even one. White blood cell casts are present in virtually every kind of renal disease. It doesn't mean infection, and if you do see it, it does mean they have underlying renal disease. It's never a normal finding. And red blood cell casts, if you remember from medical school, are absolutely pathognomonic for glomerulonephritis. There's nothing else that does it. Okay, so we could go through a very long differential diagnosis, and I think everybody would be asleep. So I've decided to do a very abridged differential diagnosis. This is it. But I like this slide. I took this from Up to Date, and normally I don't like doing that. I tell my residents and fellows, don't read Up to Date as your only source. I think it's a good source, but I have to admit I took this from Up to Date, and I like it because it shows the age of the patient and then the range of ages at which these diseases occur. And I'd just like to make a few points about the common things that cause hematuria. First, urinary tract infection is undoubtedly the most common cause. This can happen anywhere in the urinary tract, from the kidney on down through the bladder, prostatitis, epididymitis, all these things can cause hematuria. Stones, certainly. Exercise. It is not uncommon after heavy exercise to see some degree of hematuria. The urine shouldn't turn red, but to see microscopic hematuria is not uncommon. Endometriosis, quite common to see some hematuria. In African American patients, if you see hematuria, about 30% of those patients have it on the basis of sickle cell. And most of them don't have sickle cell disease, they have sickle trait. It's actually very interesting. What happens in sickle trait is that the cells don't normally sickle, but if they get in a very hypoxic environment, they do. And in the inner medulla of the kidney, the PO2 is between about 5 and 10 normally. So as these sickle trait red cells go through the medulla of the kidney, they have a tendency to sickle, and these patients have a very high incidence of papillary necrosis and hematuria on that basis. So anytime we see hematuria in an African American patient, we're always thinking about sickle cell. Polycystic kidney disease, certainly. Cancer, particularly in the age of 40 and on, and anywhere in the urinary tract, and then a large variety of intrinsic glomerular diseases. Okay, so how do we evaluate these patients? First off, who should be evaluated? Well, first, anybody who's symptomatic. We mentioned that. Hematuria in the setting of diseases known to affect the urinary tract, as I mentioned before, family history of urinary disease. Now, this is interesting. Very obese patients seem to be at increased risk of urinary tract malignancy. We don't understand why, but there's a question of if you see hematuria in somebody with a very high BMI, should they be evaluated? We don't know the answer. Then over the age of 40, I question this one. The guidelines from urologic societies are that people over the age of 40 who have even microscopic hematuria should be evaluated for malignancy. I don't know about you, but if I evaluated everybody over the age of 40 who had any hematuria, I'd be breaking the bank. So I think you have to be very careful in your judgment about this. I'd say certainly anybody over 60, over 40, I'm not certain about. I think there's still a question about that. Heavy smokers, people who have been smoking, I'd say, for at least 20 years, even if they're under 60, really should be evaluated if they do have hematuria. There's a question about whether recurrent hematuria should be evaluated. I would say it is prudent, if they're over 40, to evaluate it. There's no guidelines that say whether you should or not, but I think it's clinically prudent. Certainly gross hematuria, and then people who have an exposure history, particularly analgesics, and then there's a variety of drugs and conditions that predispose you. Okay, so how do we evaluate this? Well, obviously, you look at the urine, get a urine culture, protein to creatinine ratio, and we'll talk about that in a bit, and renal function, sort of the basic obvious things. And then actually, in many, many cases, the workup is really suggested by the H&P. I don't know how many times I see people getting the, radiology enrichment protocol, which is, you're 20 years old, you have a little bit of hematuria, you get a CT, an ultrasound, yada, yada, yada. You have to be judicious in your radiologic testing ordering. First off, along those lines, if we do need it, an unenhanced CT detects 98% of pathology. It's a very good test. CT urograms I'm going to talk about. They're excellent for detecting malignancy, but they have a very, very high radiation exposure, and they're more expensive. And ultrasound may be okay in selected patients, and I'll talk about that. Okay, so for stones. First off, in the old days, we used to get a KUB. It only has about 60% sensitivity. People with uric acid stones, they're radiolucent, you're not going to see them. Helical CT without contrast is the study of choice for people with stones. Okay? And ultrasound may be adequate if you suspect obstruction. Usually it's fairly obvious if they're obstructed. So you don't always have to go with a helical CT and ultrasound. And a helical CT, I think everybody here knows what a helical CT is. Okay. So now this at-risk patients with hematuria, how should we go about evaluating them? Well, first off, I was just talking to, who was a urologist, who said, well, the way that they work up for malignancy is to send off for 3 urine cytologies, and if it's negative, they feel good about that. Actually, I shouldn't say. I think it was a resident, not a urologist. I don't want to cast aspersions here. Anyway, it turns out that urine cytology is really a very poor screening for people that have low or intermediate, grade tumors. It's not going to detect them very well. If they had advanced grade tumors or they're more penetrating, it may. So urine cytology is not a good screening test for malignancy. If you're going to work up a patient for a urinary tract malignancy, everybody needs a cystoscopy. Absolutely required. Cystoscopy alone is not going to be good for obviously evaluating the upper tract, and for evaluating the upper tract, a multi-detector CT, and particularly a CT urogram, is probably the test of choice because it's going to get 100% pretty much. And for those of you who don't know, a multi-detector is basically you have a single source here, and then you have sort of a big array of detectors. So it gets the images through different planes, and you can reconstruct this in a computer. And unfortunately, I had a picture here that was just spectacular. Take my word for it. The images you get are absolutely phenomenal with this. And then at the same time as you're doing this multi-detector CT, you can give a dye. And so you can actually look at the different phases of this, the non-contrast, the nephrogram, and the excretory phase. And it is definitely the way to go. An IVP should not be done anymore. It will only detect about 50% of neoplasms. There's really no reason to be ordering IVPs. And there is no clear added benefit of doing retrograde pylography now. CT urogram will get what you want. In general, it helps to hydrate these patients, and sometimes we put them on a diuretic. It kind of dilates the excretory system. You can see things better. It has 95 to 98% negative predictive value, so very, very good. At least 90%, probably 95 to 100% sensitivity for upper tract tumors. So an excellent test. Okay, if you don't want the patient to get high doses of radiation, let me rephrase that. You don't want anybody to get high doses of radiation, but if you're particularly worried about the higher dose of radiation in children, pregnancy, or if, let's say, they have renal disease and they shouldn't be getting contrast, you can consider MRI urography. This also works very well. The image quality isn't as good as CT urography. There's movement artifact that can come in there. So in general, I prefer a CT urogram. Patients, if they need this, can get gadolinium. That's generally the way to do this, and it outlines the urinary tract very well. The one problem is, I said if they had a contraindication to IV contrast due to renal failure, you have to be careful about giving gadolinium to those patients because they can get this fibrosing dermopathy. It has a lower sensitivity for stones and small uroepithelial carcinoma than CT urography. So in general, this isn't as well studied as CT urography, so we can't routinely recommend it. Okay, so when do you refer to a nephrologist? If there's proteinuria that accompanies the hematuria, if there's an acute rise in creatinine, if you suspect that there's an inherited renal disease, or if there's renal insufficiency that's not obviously due to something like volume contraction or some readily reversible cause. When do you refer to a urologist? I think that's pretty straightforward. If you have a suspicion of malignancy, you can do the initial workup, you can do the radiologic screening, but then they have to have the cystoscopy. Okay, so that's the first half of the talk, and that was devoted to hematuria. Now, I divided this artificially into hematuria and proteinuria, but as you well know, there's lots of diseases that have both of these. So it's not intended to apply, well, hematuria is only these diseases, proteinuria is only these, but it's a good way to think about it, at least for purposes of giving a talk. And we'll go through diseases where they're both present. So, screening for proteinuria. So how many people in here routinely dipstick to see if a patient has proteinuria? Really? Just about 3 or 4. Either you're lying or that's an amazingly low number. And I'm very proud of you all. Except for the 3 or 4 that raised their hands. No, just kidding. So what is normal protein excretion? About 150 milligrams a day. We think, and I'm going to go into this in some detail. The main constituents are albumin, Tam-Horsfall protein, and these other proteins. But far and away, the major one is albumin. Now, why would we screen for proteinuria? Well, initial studies said, well, early diagnosis of primary kidney diseases. But primary kidney diseases don't happen very often. So it doesn't really make sense to be routinely screening for those. And then it was, well, maybe it'll serve as a guide to therapy in diseases that affect the kidney. And I think that is true, and we're going to talk about that in more detail. So, urinary albumin excretion. Albumin only comes through filtration, and it has to enter the tubular fluid through the glomerulus. If you're going to be measuring urine albumin, you really need to do 3 tests over a period of 3 to 6 months. Okay? Now, it's interesting. Microalbuminaria is defined as essentially over 30 milligrams of albumin per day excreted. But that definition was based on a definition made in the early 80s by a group that was studying patients with diabetes. And they found that diabetics who had greater than 30 milligrams of protein in their day were more likely to progress on to macroalbuminaria and sort of chronic kidney disease. That's it. Okay, so there never was any clear study to say what is normal albumin excretion in people who don't have diabetes. And this becomes a really interesting issue and one that nephrologists are grappling with. It turns out that so-called microalbuminaria is very, very high in the general population. So these 3 studies, the NHANES studies, the Dutch study, the HOPE study, all looked at patients that didn't have diabetes, renal disease, cardiovascular disease, and you can see the incidence of sort of microalbuminaria, greater than 30 milligrams a day, was between anywhere from 5 to 15% of the general population. So huge numbers. Another study, this PREVENT study, actually looked at microalbuminaria and the risk for cardiovascular death. And I wish I had my glasses because this is going to be from memory. I can't read this at all. But I think this says less than 15 here, the littlest one. And this is 15 to 30, and that one's greater than 30. And my pointer's dying, but they go from right to left. And what they show is there's a graded increase in basically cardiovascular risk as you go, even at these different levels of GFR, from less than 15 to 15 to 30, still below the microalbuminaria range to microalbuminaria. So microalbuminaria predicts cardiovascular risk. Now, does that mean that, well, okay, there's something going on with the kidney that hurts the rest of the vascular system? No, that's probably not it at all. What it probably means is that the kidney is serving as a marker for what's going on throughout the vascular system, and that you get microalbuminaria because there's general vascular pathology and the kidney is telling you that something's going on. And what we're finding is that even people that have as little as 1 milligram of urinary protein excretion a day, if they go from 1 to 3, they're actually at increased risk of cardiovascular disease. I'm going to talk about that a bit. So in this study, they're looking at microalbuminaria screening in the general population. And what you can see is that as microalbuminaria goes up, the risk for ischemic heart disease goes up. And again, this is probably more because you have general vascular disease that's being reflected as proteinuria. And in this study, what they looked at was, again, microalbuminaria in the general population. And over on the left side were two groups. And at baseline, they had people with low urinary albumin excretion, less than 15 milligrams a day, and those with high albumin excretion, greater than 16 a day, so an arbitrary definition. And then they looked at the relative risk later on for cardiovascular disease, following them up 5 years later. The people that had less than 15 and stayed at less than 15 had the same risk, about 1. But the people who went from less than 15 to greater than 15 had almost a 4-fold increase in cardiovascular risk. So a huge increase. And the people who started with a high urinary albumin excretion and maintained that had a high risk. If they dropped down, which, okay, my pointer's gone, basically their risk decreased. Okay? All right. The other thing about microalbuminaria is that if you look at these levels on the top panel, you see where it says albuminuria in quartiles. You can see it goes 1, that's 1 milligram essentially per day, to 2.2 to 3.4 to 6.5. I mean, these are all well below the 30 milligram cutoff I told you about before. But look what happens to the risk of these people developing hypertension. The relative risk goes up 1.3, 1.37, 1.76. This was the in the NHS study 1 and NHS 2. It shows exactly the same thing. So basically, this raises the question, should we be watching albuminuria really closely? Okay, so the bottom line is that microalbuminuria, it's probably worse than you think. The other thing I'd like to suggest is that we don't use the word microalbuminuria. I've had students ask me, does that mean that the albumin's really small? You know, it's really not a very good term. So the bottom line is that albuminuria is a marker of underlying vascular dysfunction. The traditional limit is around 30, but we really need to know what is a normal range. We do know that if it increases over the normal range, it is associated with increased cardiovascular disease. Okay, now after having sort of belabored the point to all of you that microalbuminuria is a bad thing, particularly if it's increasing, question is, would I check it? And the answer is no. So why did I tell you all this? Because I want you to understand that this might become an issue in the future. It's something that you have to keep an eye out for. But you could easily make the argument that if you have a patient who's hypertensive or has any kind of vascular disease, they should be maximally managed. Okay? I mean, you know, with lipid-lowering agents, antihypertensives, exercise, diet. Do you need to know what their urinary albumin excretion is? In the general population, I would say probably not. If I take somebody and I see that their microalbumin excretion is 5 milligrams a day, and then 3 years later I see that it's 10, what am I going to do about that? If they're normotensive, if their lipids are fine, how is it going to change things? So it's unclear to me at this point that we know what to do with the information. I think we're going to see studies coming out that are going to be looking at this question and saying, will this guide our therapy to maybe start ACE inhibitors in somebody who's not hypertensive, who's getting increasing microalbuminuria? At this point, we don't know the answer. And I apologize for not giving you the answer to it, but this is where we are. This is the state of the art. So, is it ever worth measuring? Absolutely. So who do we measure it in? In two populations, I'd recommend absolutely measuring it, in diabetics and in hypertensives. So this is one, you'll just have to take my word for it. This shows that before a patient has microalbuminaria, so they have normal albumin excretion and they're diabetic, if you start them on ACE inhibitors and you follow them over about 5 to 10 years, the people who are started on ACE inhibitors, even before they're microalbuminuric, do much better. They have preserved renal function, much less evidence of proteinuria. So what should we be doing? In type 1 diabetics, we should be starting screening after 5 years of disease. People don't get albuminuria within the first 5 years. Microalbuminaria in the first 10 years of the disease usually indicates they're going to progress to macroalbuminaria, and they're going to have cardiovascular disease and probably renal chronic kidney disease. Type 2 diabetics, microalbuminaria progresses to overt nephropathy in a third of the patients. So right now there's about 500,000 patients on dialysis in the United States. 50% of incident dialysis patients are there because of diabetes. This is far and away the biggest cause of end-stage renal disease and chronic kidney disease. So we need things to intervene here. Sorry, let me go back. So an early intervention reduces albuminuria and preserves renal function. So I would be screening these people every 6 months for albuminuria. And I would do it at the start of the disease. As you all well know, most of the patients you see who come in with type 2 diabetes, you can't really say when it started. So it's important as soon as you get them in your clinic to be checking every 6 months. Okay, in hypertensives, this goes back to what I said before, the HOPE study, the LIFE trial, and a number of other studies showed that if you're hypertensive, microalbuminuria independently of everything else increases the risk for cardiovascular death. So, should we be screening for microalbuminuria in hypertensives? This is very much an open question. So, in patients with mild hypertension and no other risk, if they have microalbuminuria, let's say greater than 30, you can say for sure those people are at increased risk of cardiovascular disease. There's increasing evidence that suggests microalbuminuria in low-risk populations portends worse cardiovascular outcomes. So although this isn't any official recommendation of any society, my recommendation, and I think this should become a formal one from societies, is that if a patient is hypertensive, I am going to be screening them for microalbuminuria, and I'm going to be doing it on a yearly basis. Now you could say to me, well, what are you going to do with the information? And what I would do with the information is most of my patients that I see are people that other people have trouble managing their hypertension. I don't get simple hypertension. But most of my patients do not have normal blood pressures. And part of it is compliance with diet and medications, etc. But if I see that they have microalbuminuria, and particularly if it's increasing, then that is something I can use to educate them that they are at particularly high risk of getting into trouble of cardiovascular disease, and it also spurs me to work even harder to get them under control. Now you could argue with it, but that's in general my advice, what I would be doing. Okay, so lab testing for proteinuria and albuminuria. Okay, for proteinuria, we were looking at generally the dipstick is very, very sensitive here, 95 to 99% sensitivity. You can get false positivity. I see this not infrequently in patients referred. If they have a urinary tract infection, a lot of cells, it's false positive. Also, if they've had radio contrast within 24 hours, you can get a positive dipstick. The other thing that I think is quite interesting is that Bence-Jones proteins are not detected by the dipstick. So the albumin is negatively charged. It reacts with the hydrogen peroxide in the dipstick, and you develop the color. Bence-Jones, being positively charged, don't react. So if you suspect somebody actually of having myeloma or light chains, a dipstick is not a good way to look for it. Albuminuria, there is a large variety of dipsticks out there. I just listed a few. There's even some now, Bayer has one, there are others that will measure microalbumin and creatinine at the same time and give you a ratio. At this point, I wouldn't recommend them. They're pretty poor sensitivity. You may get somebody advocating for them, but I don't think they're ready for prime time yet. Okay, laboratory testing for these. So first off, there is no reason ever to send off a 24-hour urine protein. You don't have to do it anymore. There's very, very good data that says, particularly in early morning, urine protein to creatinine ratio is just as good. And it's probably more accurate because patients don't do a very good job of giving you a 24-hour collection. So the 24-hour isn't necessary. The urine protein or albumin to creatinine ratio, the number that's reported back to you, is equal to grams of albumin or creatinine, albumin or protein in the urine a day. It's very simple. The one caveat where this might not be perfect is people that have very low creatinine excretion or very high. So people that are markedly undernourished, the very elderly, people that, bodybuilders can throw this off a little bit. In those rare circumstances, you could get a 24-hour urine protein, but that would be it. Now, in general, the question comes up whether we should be measuring albuminuria or proteinuria. For diabetics, this bottom thing here, and for hypertensives, the urine albumin is the way to go. Don't do a protein, do an albumin. The albumin, changes in albumin have been tracked very well with changes in vascular function and risk. For other patients, particularly for pediatric patients, it turns out that proteinuria is better. And that is because kids can have a variety of proteins in the urine other than albumin, and those proteins can make up a larger percentage of the urinary proteins than in adults. So in kids, we like to see urinary protein ratios. Okay, again, a very abridged differential diagnosis of proteinuria. This is the kind of stuff that we see quite often, but most people don't think about out in the community. These are proteinuria, where it's the major manifestation, and this first one is called benign transient proteinuria. Amazingly enough, it's called that because it's benign and transient. And it's because you see it once and it goes away. Nobody knows why you had it, and it's less than 500 milligrams. The point is, you have to get 3 urine protein collections before you make any clear diagnosis. The next one is called functional proteinuria, and this can be up to about 1 gram a day. It's transient, and it's usually associated with severe stress. So somebody who's run a marathon, a very high fever, somebody in the ICU who's got heart failure. I was going to say congestive heart failure, but after the last lecture, I've taken the congestive out of it. And basically, they can have proteinuria. We're not sure why, but when the stress is gone, the proteinuria goes away. So it's not really useful to make any statements about proteinuria during conditions of severe stress. And the last one's a very interesting one called postural proteinuria. We see these in adolescents particularly male. And what happens is they have up to 1 gram of proteinuria when they're standing. When they sleep at night, they don't have any proteinuria. So you can tell the difference. Well, first you wouldn't work it up unless it were pretty much a male adolescent. But you can tell the difference by getting a urine collection during the day and then a morning urine collection. And this does carry a slight risk of chronic renal failure. Okay. The next group is sort of the biggest one that we see, where you'll refer somebody in who's got more than a normal amount of proteinuria, but not nephrotic range. And these ones are tough. They might have completely normal GFR, but 50% of these patients develop hypertension within 5 years, and 20% develop chronic kidney disease within 10 years. So it's a bad thing. It needs to be paid attention to, and we like seeing them in our clinic. It may be that we'll see them and send them back to you for follow-up, but we like seeing them. The major causes are just early diseases: hypertension, diabetes, GN, interstitial nephritis, anything that can affect the kidney. Now, nephrotic range proteinuria, there's a variety of causes, and in general, you should always refer somebody with nephrotic range greater than 3.5 grams a day to the nephrologist. Okay? There's no exceptions except one, and that one is diabetes. So diabetes is the most common cause of secondary nephrotic syndrome. We talked about how common it is from the ESRD. Retinopathy is usually present. So if you see somebody who has nephrotic syndrome, they're diabetic, and they've got retinopathy, neuropathy, you can pretty much bet that that's due to the diabetes. The nephrotic syndrome is due to the diabetes. An important point, and this is the one I kind of harangue on the house staff for, is that if you see somebody and you're sure of the length of the time of their diabetes, and that's not an easy one because you're not always sure, but if it's been under 10 years, they cannot have nephrotic syndrome due to the diabetes. So if you've been following somebody for 3 years, they're diet controlled, their glucose is, their hemoglobin A1C is 6.5, and they come to you and they've got 5 grams of proteinuria, they need to see the nephrologist because that is not diabetic nephropathy. It's something else. They have to have diabetes for at least 10 and more like 15 years before they're going to get nephrotic syndrome. I'm just going to make a very brief point about the primary GNs, and that is that from the most trivial one, minimal change, to the most severe, a rapidly progressive GN, you can't tell them apart. Any of them can have nephrotic syndrome, any of them can have hematuria, any of them can have decreased GFR. So the point is, if you suspect a GN, the nephrologist has to see him. You can't tell by the urinalysis what's going on. Okay, so how do we evaluate these patients with proteinuria? First off, obviously the initial laboratory tests, the urine protein, the creatinine ratio, examination of the urine, and then workup is directed, obviously, by the H&P. So what do? If they have less than 1 gram of proteinuria a day without hematuria or renal dysfunction. If they have renal dysfunction, then obviously, that needs to be evaluated separately. But if they have less than 1 gram and normal renal function, I allow the factors which could cause functional proteinuria to resolve. Recheck the urine. You want to check it a total of 3 times at least. And if it's normal, then it's just benign, transient, or functional. If it's persistent, I would refer them to nephrology. Again, nephrology may only see them 1 time, but if they have 700 to 800 milligrams of proteinuria, normal renal function, that is not benign. There's some underlying renal disease going on, and maybe that will send them back to you and say, we're not going to do anything yet, but we still want to see them. Okay, what about persistent non-nephrotic range proteinuria? This kind of summarizes what I was talking about. If there's renal insufficiency, we need to see them. If there's not, is hematuria the biggest component? In other words, do they have macroscopic hematuria? If they do, that has to be worked up. If they don't, then the diagnosis essentially is worked up by you initially, controlling blood pressure, ruling out diabetes. We preferred if you got a renal ultrasound before you sent them to us. And if they're older than 60, everybody should have a protein electrophoresis. Okay? And then basically you monitor the renal function and send to us. The final one is if they have nephrotic range proteinuria, the one thing I should do a bit of a disclaimer. I say you do not want to do the ARUP enrichment protocol, but the disclaimer is that my wife is the chief medical officer for ARUP, so I have a conflict of interest. But the bottom line is somebody has, people suspect is a glomerular lesion, and they immediately send off every collagen vascular test known to man. And these things have to be sent off judiciously. There's a number of institutions now which have renal panels, and you can just go in and you say, aha, I saw some hematuria and some proteinuria, so I'm going to send off all of these things. In general, we really don't want these done in advance except the SPEP. if they have nephrotic range proteinuria, except in that one case of the classic diabetic who's already got nephropathy, retinopathy, they always need a renal biopsy. Okay? If they have nephrotic range proteinuria, we should be seeing them. If they have diabetes, we probably won't biopsy them, but otherwise we will. So anybody who has nephrotic range needs to be seen by us and needs a biopsy. Okay, so to summarize, routine screening for hematuria and proteinuria is not justified. It has to be in at-risk populations. The diagnosis is often made by the H&P, urinalysis, and a few blood tests. Extensive radiologic routine workup is not necessary, and it should be tailored to the suspected diagnosis. Refer to nephrology for hematuria unexplained by the above or persistent macroscopic proteinuria. And I'll conclude there. Thank you for your attention. Okay. Right. Right. So the question is, what do you do with a young person who comes in who's got positive dipstick for hematuria, but microscopy is completely benign? Unless there's something in the H&P that suggests that I need to work up that individual, I don't do anything. And in terms of routine following that person, I have to be honest with you, it makes me nervous to kind of just leave it. So if I happen to see him again, I'll probably repeat the dipstick. If it's negative, I'll feel good about it. If it's positive, I'll say, I'm still not going to work them up, but I'm going to kind of red flag this. So if they come in for other reasons, if it increases to where I start seeing sort of either macroscopic hematuria or significant red cells in the urine, that's recurrent hematuria, and then there's a question about what you should do with those people. I think a young person who doesn't have any reason to have a malignancy, you probably wouldn't work them up at all, but just kind of have a heightened awareness in them. Okay? Yes? Yeah, so the question was, when do you get the microalbumin to creatinine ratio versus the protein to creatinine ratio? And what I had said was, in the diabetic and hypertensive, you get the albumin to creatinine ratio, and in kids, you get the protein to creatinine ratio. In adults, generally, probably getting an albumin to creatinine ratio is a reasonable thing to do. You could say that across the board in all spectrums of adult diseases, that would be reasonable. The one exception would be if you think somebody might have myeloma, obviously they might not have much albumin, they're going to have myeloma protein in the urine, but you're going to find that out for other reasons. Okay? Yes? So I can tell you that I think I see about 5,000 of those. And I don't think that it should be routinely done for exactly the reasons that I iterated. It has a very, very low positive predictive value in an individual that young. Yeah. And in fact, it has caused more trouble than it has really benefited, because people get labeled as having, let's say, a bit of protein in their urine, and it can be used to adverse effects by insurance companies. And so we don't do anything about that. Like I said, as much as 5 to 15% of the population might have microalbuminaria, and we just don't have any reason to work up those people or to be routinely screening for it. Yes?
Don't all the kids that play a hard basketball game show positive protein on the dipstick the next day anymore?
The question was, don't all kids that play, heavy sports show up with a positive dipstick? I don't know the answer to that. I don't know that that's been systematically looked at, but you do see it a lot, and particularly people that do heavy exercise. You look at urine protein the next day, it's slightly elevated. Yeah.
How long would you wait in between dipsticks on somebody you had a positive on?
I would do it over a period of 3 months. I'd wait a month. Yeah.
So thank you very much. I have 2 or 3 quick announcements, actually. One is that McKay Hospital has offered to do laboratory testing on attendees here at the conference tomorrow. For men, the screening would be a lipid profile, glucose, and PSA. For women, a lipid profile and glucose. $20 for men, $15 for women. You have to sign up to get it done. Sign up is at the registration desk. Fasting for 12 hours after midnight or so. 12-hour fast is what they recommend. And the blood draws will be from 8 to 10 tomorrow morning. So if you're interested in that, got to go to the front to the registration desk, sign up for it, and $20 or $15. So, second announcement is just to remind you to visit the exhibitors. You'll find out Friday at my financial report how much of an impact they've made this year because our foundation took such a hit as the rest of our 401ks and so forth. So support the people that are supporting us. And then lastly, Health Insight, for those of you interested in more continuing education credits, P4P kind of stuff, the family practice people that need projects for their board certification, Health Insight is a great resource. They're here, they've got a booth, and so we encourage you to visit them. So our last speaker is Rich Engebretson. I don't see Rich. Oh, sorry. Okay. I think we'll just move right on. Rich is a native Utahn, okay, and he bleeds red for sure, and had a bit of a circuitous route to get to medicine. Started initially as a biology major at University of Utah, and then his master's degree and PhD are actually in physics. So he then did his additional training in internal medicine at LDS, but he actually wears 3 hats. He is clinical and faculty in the internal medicine department at the university. Also teaches in the Department of Physics, interestingly, has some courses on medical physics that my son has attended actually and really enjoyed. And then he also wears a hat. He works as an emergency physician at St. Mark's and as well at Brigham City. But his passion is the canyons of southern Utah. And for a number of years, he's actually was the founder of the Glen Canyon Institute, and he's also on the board of directors of the Southern Utah Wilderness Alliance. Medically, he founded a number of years ago an organization called the Wilderness Medicine of Utah, and he's also president of the Wilderness Life Support Institute. So obviously wears a lot of hats, a lot of interest in wilderness medicine. Rich and I did a couple river trips together years ago with our Family Practice Academy, so he does it almost every year, certainly is an acclaimed river rat, wilderness medicine expert, and passionate in that area. Please welcome Dr. Engebretson.
I don't know if it operates yet. It will be operating? Well, I can tell you. I actually went on a river trip with Frank and Frank's father. Do you remember that? We went down over on the gates of Lodore. While I'm waiting for the pointer so we can move forward, about 12 or 13 years ago, it was in 1993 actually, so that's 16 years ago. I had just graduated from medical school, and was up with a friend who was a dentist and an emergency medical technician, and we saw a biker crash quite severely. And it was very disconcerting to me. I had graduated from medical school the day before, and I did not know how to treat this guy. I did not know one thing what to do. This guy was on the ground, unconscious and bleeding, and my friend, who was a dentist but an EMT, knew everything what to do, and stabilized him, got his neck all working, and soon a little crowd of people gathered, and then an internist pushed his way through the crowd. And this is after my friend had established, made sure he was breathing and his neck was stable, had sent someone for help. This internist, and I only say it's an internist because I was heading into an internal medicine program, and he pushed through the crowd and said, "Stand back, I'm in charge, I'm an internist." And then he knelt down and just started to yell at this guy, "Are you okay?" without doing anything. And the only difference between him and me is that he spoke and I didn't. I both realized that neither of us knew what to do in the back country when someone gets injured. So I began investigating it, and this is how I hooked up with Frank Brown, which was a lucky blessing. And for those of you who know Lee Schussman, we started working on developing treatment guidelines in the back country, and ultimately with the Wilderness Medical Society and Paul Auerbach, and finally with the United States Army and the School of Medicine. So with that, those wonderful doctors, and I can't leave the medical students out because they're so diligent, but the Army, Paul Auerbach, and the School of Medicine faculty, Frank and Lee and others, we have developed a set of protocols, and the Wilderness Medical Society, I can't leave them out, of how to treat people in the back country, and some guidelines. And one of the things we had to do is get rid of myths, and I'll just tell you one before I do these cases. For example, who in here has been taught that the way you treat a snake bite is to cut it open and put your mouth on it and suck the blood and the venom into your mouth? Now, who's been taught that? Now, who would do that? Is that ridiculous? But yet that's what we were taught. And no one has ever not changed that. And no one's not taught us differently. So we went about we've gone about trying to change that. And the same thing with spider bites, for example. Who here swears that someone's come in and said that they've been bit by a brown recluse? Is anybody? Well, brown recluses just don't bite, and there's a lot of studies in the New England Journal of Medicine and others, and the entomologic journals that say they've studied spider bites in Florida, North Carolina, other places, that they've listed hundreds of brown recluse spider bites, and they've never found a brown recluse in the state. So there's a lot of myths out there, and one of the things we try to do is teach these CME courses and certify people, and what we've now, the School of Medicine calls Advanced Wilderness Life Support. By the way, we're teaching a course here on the 12th and 13th in this building in Ogden. If anyone's interested, go to awls.org. If I do this right there, awls.org, and take a CME course and learn how to treat people in the back country. Well, let's just do some cases. That's all we'll do, and you can see some of these things. A lot of these I was involved with, a lot of them I wasn't. Let's just do these. It's all just backcountry cases. Bike injury. 17-year-old male crashes while riding his mountain bike. His neck hits the handlebars. He immediately has trouble breathing and starts to cough up blood. I was involved with this case. This happened up in just east of Ogden, actually, on a bike trail up there. And by the way, before I do this case, a lot of people say, well, I don't go into the backcountry. I don't go into the wilderness. Your wilderness experience may start the minute you step out of the car up in the Uinta Mountains on a picnic with your family. And you go 100 feet off the trail and you sit down and something happens. You're surrounded by mosquitoes, or you're out in the sun, or you get hit, you touch a plant that is toxic. You don't have to be hiking down the canyons in the Escalante River or having to be skiing high up in the mountains. Your wilderness experience may happen with someone having a heart attack with a family, or you be with the scouts, or somewhere where you're just enough out there that it's out of your comfort zone. So that's what we tailor our wilderness medicine courses to, is not a super advanced science, but to all of us who go out. Well, let's look at this. So this 7-year-old kid crashes. It's only apparent injury. You're an hour from help. He has no other medical problems. So this is a guy, falls off his bike. He hits his handlebars on his neck. That's his only injury. He's coughing up blood and having a difficult time breathing. So what is the next step in the management of this case? This is just about 5 miles up the trail here. Send someone for help. Stay with the patient. Begin mouth-to-mouth resuscitation. Put the patient in your car and take to the nearest hospital, making sure he is upright and his head is stable. I think there's one more. No, that was what they did. So that gave the answer that what actually did happen is, the assessment of any patient is always A, B, C, D, E, airway, breathing, circulation, disability, usually the Glasgow Coma score, or maybe just a blister, or the environment, are they hot, cold. In wilderness medicine, we advance that a little bit. And remember, there's one myth we want to get rid of, and I'll mention it now, is if they're breathing, their airway is not clear. Now, if you're in the back country, in wilderness, and someone you're worried about their breathing, if they're speaking, they can still have rocks, broken teeth, snow in their mouth. To clear an airway, you have to open their mouth and look in. Now, the general public, we don't teach the mouth sweep anymore because they were finding they were pushing stuff in. But you know better, and you can clear an airway. But remember, when you clear an airway, if someone's down unconscious, open their airway. Look in and see if something's covering their mouth. Open it. The last lady I had to treat in the wilderness had fallen off a small cliff, and they started screaming my name, and a 78-year-old just, boom, went down off a rock. She was laying in blood, unconscious around her head. Well, it takes your breath away. I'm an ER physician, but I'll tell you, out there, it's all of a sudden, oh, what do you do? Well, make the scene safe, and then go open their airway. So open her mouth, and I had to put the blood away from her. She turned out she was unconscious, broke her wrist, cut herself. She turned out to be fine. But, initially it's scary. Well, let's go back to this case. So this guy, they took him to the hospital. There's a case in this. The patient needed to be upright or he struggled to breathe. If he turned his head or went any other way, he was losing his airway. He had a little cup of blood. It was filling up, and so his lungs were filling up also. He was taken by car. They threw their bikes in the back, and they just held his head, and he was starting to turn blue and get quite sick. As time progressed, his airway became very edematous. In fact, this is actually when I saw him. His neck was so swollen beyond belief, I couldn't do a trach on him if I had to. And the anatomical landmarks were lost. So this is a good case of if this were you, how would you keep an airway open? Well, this actually was now in the ER, so we're out of the wilderness. I called Colin Grissom down at LDS Hospital. I said, I have a guy that's going to die unless we do a trach on it, but his neck's so swollen. So what we ended up doing, he did lose his airway, put a needle down here. I just grabbed the biggest needle that I could find and put it in, and we put a Venturi jet on him, and we breathed for him. And it ended up saving his life. This is the kid, and this is right after they'd done the trach on him down at LDS, the medical surgical ICU down there. And what they did is they did an upright, awake trach on him. They couldn't lay him down or turn him. And we couldn't intubate him because the mouth was just so bloody. And they did the reconstructive surgery and went down and saw him. The surgery revealed a severely injured airway, and he had been breathing through a fistula, through just clumpy things of clotted blood. If you tried to intubate him or turn his neck, he would have suffocated. But what saved him was putting the 14-gauge angiocath in his trachea, and then we breathed for him. Subsequent to that, this is the discussion. Medical professionals need to be able to deal with a compromised airway in the back country. So a nurse said, Rich, what you can use is carry in your first aid kit. Here's the IV bag, and then you put that big thing up in it. Just cut that off that needle and stick that in if you have to. Now they make them. You can actually get them off the internet. They take those needles, and you can do that. And then you can breathe for them that way. Oh, my gosh, wouldn't that be awful if you were in such a situation? But it happened just here with some kids east of Ogden when they went up there and crashed their bike. So it doesn't take much to get in that situation. So improvisation may be needed to keep an airway open. If you don't carry an angiocath that you could breathe through, that's tiny, carry the bottom end of a needle if you need to open up an airway. By the way, that was the easiest cannulization I ever did. You know, putting in a central line or doing an art line. Sticking a needle in a trachea was easy. It was there. I just popped it in and he was fine. And you just know where he is. So what's in your first aid kit? First case. Okay, second case. This happened up in this area also. I wonder if anyone knows this case. A 45-year-old man is on a snowmobile in northern Utah about 2 hours from any city. He's traveling through the trees when a large tree limb strikes his right leg. He's knocked off the snowmobile. The branch breaks off in his leg. That's an interesting case. Well, now you're in the back country. So if you snowmobile, all of a sudden you're a wilderness medicine doctor or a wilderness medicine professional. By the way, anyone can certify with AWLS if you're an EMT, a dentist, a nurse, PA, and we welcome you all to that because it's such a sort of a low-level entry. What is the next step? After the bleeding is controlled, remove the tree limb and clean the wound as best as possible. So you're up there in the mountains, snow all around you, put some ice on it, I guess. Keep the limb in place, trimming the large part that is sticking out. Leave the limb in place and go to an ER. Just take off. What would you do? Oh, there's the answer, maybe. Call search and rescue. That's what Lee Schussman was in charge of for all those years. Well, what they did was they left the limb in place and they just hightailed it down to the ER where we saw him. And that's a limb. He's conscious, alert, breathing, only in moderate pain. So, assuming that's in the back country, what would you do? Now, that's on the stretcher going to the OR, but what would you do out there? So this is a wilderness medicine case. This is not what you study in medical school. There's not a chapter in Robbins' pathology, limb in leg, to study. So should you take it in now or leave it out? There's a better view of it. So this was the peroneus longus and then the peroneus brevis muscle. It actually just bisected those muscles nicely. Not a whole heck of a lot of blood coming out of it. Look how denuded it is, though. And look how it isn't here. So you know it's right there. And so the debate you have on this is, if it were days, let's say you're in Yellowstone on a snowmobile and you're 2 days from help, then what do you do? Do you leave this in or do you take it out? Well, these are the big debates of wilderness medicine, and there's often no right or wrong answer to this. But if you're just a half an hour from an ER, go to the ER. But if you're 2 days out or even 3 days, 1 day out, you might want to take this out and bandage it and hope that you didn't cut a major artery. You know, you'd have to think about this and see the situation where you're at. He did well with this case. So this is sort of the unusual cases that appear in backcountry medicine. Medical professionals should be able to handle a wide variety of cases with improvised treatment. And use your best sense, because in some cases you can't have protocols in backcountry medicine. You just have to use your brain. This is a famous case, and we illustrate it for a variety of reasons because it has a lot of value. Many of you know this story. There's books and some TV shows about it. In April 2003, Aaron, with one A, Ralston, was climbing alone in Blue John Canyon of the Maze District of Canyonlands National Park south of Moab. Actually, it's a little more west of Moab, Utah, when he dislodged an 800-pound boulder that fell on his right arm, pinning him against the rock face. This is the canyon where this happened. There's the rock that it happened. Oh, there's the rock down there, sorry, that it happened. He was sliding over the boulder and had put his hands up on the rock to slide down, and as he slid off the boulder broke loose and it fell with him. And he landed, pinning his hand just at arm level. He could have been hanging, which would have been horrible, but he landed on his feet, just stuck. And he stayed there for 5 days. He was stuck on this rock with his hand stuck right there standing, and he had enough food and water to keep him going. And then, if you've heard him speak or read his book, he was trying to whittle away at the rock. He cut his hand, and just gas came out. And he knew his hand was dead. So he decided to whittle it, which is what he did, and then he cut the median nerve and just snapped the bones after he put a tourniquet on and freed himself. And interesting, so he could do all of that. And what was more interesting is he filmed the whole thing. And if you buy his book, you'll get a very good idea of what he went through, because I didn't include the picture, but after he freed it, he took a picture, and this is the bloodiest thing I've ever seen. And but that was right before he filmed it. He thought he was going to die, so he left messages for his parents and family and everything. So that was just moments before he cut his hand off. That was the tool that he used to cut it off, just a Gerber or a knife or one of those. He was 27 at the time, experienced outdoorsman. He had been a member of a search and rescue team. He knew the rules of outdoor. He failed to leave word with anyone of where he was going. What happened, his mother got worried, called the sheriff in Utah, and they found a charge receipt at the city market in Moab, so they knew he was in the area. They went up on a helicopter looking for his car, found it over west of the Colorado, and then at the same time he had actually rappelled with one arm down a 70-foot cliff and met a couple from Belgium who were walking him out when the helicopter picked him up and took him to Moab, where they completed the amputation. Then they flew him to Grand Junction, where he got done. But he was hiking alone. No one knew where he was. And it was just sheer determination on his part and luck. And by the way, this was not the only case of self-amputation that we found. When we put this talk together, we found a number of cases of self-amputation, 3 or 4 arms and a couple of legs that people had actually amputated to get themselves out of the bind that they were in. This is probably the most famous case and the one with the greatest outcome. This was his online case. To me, it was the same decision a lot of us make about going to the grocery store around the corner to get a gallon of milk. For me, that was the level of risk I was anticipating for the day. That was the greatest mistake I've made in my outdoor career. A bad mistake. And, he charged, and it's made a lot of money on the loss of his hand, but losing your right hand is not worth any amount of money. And now he goes around lecturing on this and helping people to do better. Now he's very active again. But what a mistake. So the reason we put this in is going off in the wilderness alone is risky. Not telling anyone where you are going is even worse. Plans need to be made for rescue if you do not return at a specified time. And when you are the leader and you are taking people out, whether it's your family, the neighborhood, kids, you've been asked to be the group leader as the medical professional, make sure you've got these plans, contingency plans. You will never, ever regret it. This is a case that happened in Idaho, and I apologize in advance if anyone knows this case. I've given this talk a number of times, and this case is a very sensitive story. And a year and a half ago, I gave this at an AWLS course in Moab, and this kid's girlfriend was in the audience, and I didn't know it at the start. But the father and the family have asked me to present this. 22-year-old male is kayaking on the Payette River in Idaho. This is a beautiful river, and every time I drive past it, I admire it, but refuse to go in it because it's scary to me to get into. And that's where Walt Blackadar, who was a physician out of Idaho, was killed on that river, who owned Blackadar Boating. I don't know if anyone here knew him, but it was a famous story. He overturns in a rapid. The rapid was Jacob's Ladder, which I'm not familiar with because I don't float that river. When you get to him, the helmet is pushed back over his head, and he has an abrasion on his forehead. So that's how you find your friend. He's a young kid, turns over in a rapid. You don't see him come up, so you take off after him, and you find him unconscious with a big bump on his head. He's unresponsive. Now, this is the rapid that he was in, that Jacob's Ladder, and this is another view of Jacob's Ladder rapid. So you can tell that you have to be proficient and good. It's full of rocks, which also means danger in backcountry medicine. There are no industry standards for whitewater helmets. His helmet had pushed back. Even though the helmet was on, there is Lucas Turner, even though worn appropriately, his helmet had slipped back off his head, and he had struck his head. So what is the next step in the management of this patient? Begin CPR immediately. Check for scene safety, then begin ABCDE of the primary survey. The first step is to send for help. Pull the patient from the water and tend to his head wound. Well, the answer in any time we evaluate any patient, although we don't always do it, is check for the scene safety, then begin airway, breathing, circulation, disability, environment of the primary survey. That's always the answer. We don't always check for scene safety in our office unless the nurse is real mad or something, and then things aren't so secure. But you just don't worry about scene safety in hospitals and offices. And we don't always check for airway because a patient comes in and sitting down talking to you. You don't worry about the airway. But in backcountry medicine and in ER medicine, you always open their mouth and look in their airway. It's the first thing you do on an injured patient. Open their mouth. Check to make sure the scene is safe, then open their mouth and look in it. At the scene, the friends did that. They pulled him from the water. He wasn't breathing. They opened his mouth. They did all the right things. They began CPR, and Lucas Turner, a 22-year-old kid from Salt Lake on the Pitt River, died that day. It's a very sad story. His death was officially listed as being secondary to a long swim, but this is inaccurate. Now, American Whitewater every year lists the deaths by drowning, and that year they listed Lucas's death as a long swim, which means we really don't know how he died. He just was swept away. By the way, the last drowning on the Colorado River was a year and a half ago on Westwater Canyon, where a lady was swept away and she drowned. A 52-year-old female was with some rangers and actually just overturned in the first part of the canyon, was just swept away, and by the time they got to her, she was just dead. She had hit a bunch of rapids, didn't hit her head, no broken bones, no heart attack. She just had breathed in water and drowned. And that sometimes can happen, but that is not what happened here. He died of a head injury. Now, why do we include this? Well, as we got into this, Lucas's father heard what we were doing, and he came to the School of Medicine, and he would give these lectures, and he became so emotional that we stopped asking him because it was too hard on him. So he asked us if we would talk about this case because it's a telling case. Because a lot of us in here have family members who kayak or go do exercises, and they wear helmets. But this didn't save his life. It actually hurt him. Now, Gil Turner asked me in these programs that we teach nationally if we'd show his dead body. So at Gil's request, I'm going to show it. You do not need to look at Lucas's head injury if you don't want, but here it is. This is how Lucas died. He hit his head right there. And after they pulled him out of the water, he died of a head injury. That's how he died. Now the company that made this helmet was fearing a class action lawsuit because after they heard that Lucas had died, a number of people were getting together, including Gil Turner, to sue them. So they just went away. They just went away. They didn't sell the business. They just went away. And they no longer make this helmet, although it's a common helmet. It's bought at REI, and it was about $75. So all the kayakers used this helmet, but it had pivoted back over his head. Now this is the problem. It illustrates a major misconception in whitewater helmets, and this is one of the things we like our students to know, is that helmets may or may not be safe. Because what happens when you go biking or skiing, the first thing you hit when you fall, like if you're a biker, is you hit your helmet on the ground. But in whitewater, the first thing you hit is the water, and it can push it back. And that's what happened to Lucas. So that's what we want to bring up. Well, what Gil did is he didn't sue. Instead, he came to me and my little brother, who was a biomechanical engineer, and said, I want to make a better helmet and make it in honor of Gil, or of Lucas. And I sent him to my little brother, and he gave him some advice, and Gil just sort of vanished. We didn't see him for a while. And then, 2 years ago, this month, I got a box in the mail. We all get them. I open it up, and here's a whitewater helmet, this beautiful helmet. Oh my gosh, who's sending me this? You know, you get these things occasionally, not a lot, but you do. And I called up my little brother, and I said, Dave, do you think this can be Gil's new helmet? And he said, I got one too. He said, I got it too. So we thought it has to be. So I was looking at this helmet, and I opened it up, and on the inside visor, it said in just cursive writing, emblazoned, not colored, but just the same color of the plastic, it said Lucas Turner on the helmet. And I got this chill up my back. He did it. He made the helmet. He had gone and done this. Now, we're not supposed to, in these CME conferences, promote a particular product, but I'm not promoting this. I don't own stock in this company. I'm just telling you the story. And this, I went straight to the internet, and this is the article that I read. 7 years ago, Lucas Turner set off with friends and was killed in a fatal blow to his forehead. Gale agreed to begin a project to design a better whitewater helmet, and the process changed safety standards for the industry. And then he went back to Hopkins at that public health program they've got there, which is so good, and here are the engineers that did it. They're strapping this new helmet with, look at these two straps on it, goes underneath. Then it's got this thing that comes down in the back of the head that clamps it on the head. And then, of all things, put a fire hose on it. And the article shows it from all four angles. It doesn't come off. This helmet sticks to the head. And I'm just going to tell you about it. It's the name of it. It's called the Current. It's the same price as the other. It's got a superior retention system and so forth, and it's called the Whitewater Research and Safety Institute. If you have kids, brothers, sisters, anybody that you know that whitewaters, tell them about the Whitewater Safety Research Institute, and you may save their life. Yes, sir. It's unbelievably comfortable because it's got pads all in it. It's like rubber and padded, and it comes down, and two straps back here. It's extremely comfortable. It's open, and it's great. It's a wonderful helmet. It's great. Thanks for asking. Whitewater helmets hit the water before they hit an underground rock and may pivot backwards. Helmets must not only be worn in outdoor activity, they must also be protective. So be careful. Helmets may or may not be good, especially if you're in the whitewater. We're only going to do a few more of these. In August 2005, a trip led by a University of Utah professor traveled down Cataract Canyon on the Colorado River. And I'm not going to tell you who that professor was, but he's a real nice guy, and I know him real well. I'm embarrassed to tell you who it was. On the morning of the third day of a 5-day trip, 5 people out of 35 began having symptoms of food poisoning. Okay, it was me. I had all medical students and a bunch of doctors and their kids on this trip. And in the third day, here we are, getting ready to run these huge rapids. And 5 people came waking me up at 5, 6 in the morning. They're vomiting and they have diarrhea. What a nightmare. This was a horrible situation. The sky was clear. The temperature is 100. There's Cataract Canyon down there. The biggest rapids of the trip were ahead. None of the 5 could keep water down. Now, that's a bad thing in the desert. They're already dehydrated. They can't drink water. Now they're vomiting. Now they have diarrhea. They vomit, diarrhea. We are in the middle of the wilderness. We're nowhere for help. You can't walk to help. You can't drive to help. You can't take your raft to help. We are stuck in the middle of the wilderness on a hot day with dehydration and people that can't keep water down. These people need to go to the ER and get fluids and need to be cool. So this was the situation we found ourselves in. What is the correct management of these patients? And there's a rapid on Cataract Canyon, so that's what we had to deal with. We have sick people going through that. This is an absolute horrid situation. Is it safe to take these patients through the rapids? Well, these were our choices, and we debated them, and I'll put them up to you, and we kind of discussed them. We got the doctors, we got the students, and we just sat down. I'm the director of the trip. Send one guy down river in a raft, just alone with a motor, and get help from the National Park Service. We didn't have a sat phone, which we carry now. But are we going to watch these people and go get a helicopter? It would take it all day. They might be able to get in it that night, or it would certainly be the next morning. Put all the people in one boat and just get them the heck out of there as fast as you can. Get them on a motor, lighten up the boat, and just hightail it out. Well, we decided against that because you don't want to run rapids alone. They're big. If you flip, now you've got 5 people that are sick in the water and 1 guide. I mean, so we quickly dismissed that one, even though we talked about it. Put them in several of the safest boats. Try to keep them cool and reassess them as the day goes down. In other words, just move out as quick as we can as a group safely and just watch them. Most food poisonings, 24 hours, 18 hours, maybe they'll be better by the day, and we'll keep them cool, keep them covered in the boats. Or just sit there for a day, see what happens. Well, you're running out of food and water. This is a scary situation. Well, those were our choices. I mean, there's no other choice. And we thought and thought and we talked, and these kids were vomiting and had diarrhea, and we thought, well, the sitting in 110-degree heat on a hot beach didn't sound good. We didn't want to lay over, so we put them in a boat. This is what we did, is we put them in this biggest boat, safest boats, put them on the bottom, covered them with towels, with water, kept them cool, and just went through as safely through the rapids as we could. And lo and behold, by the end of the day, by the time we got to camp, they were all feeling pretty good. You know how it goes. Most of us have had that 24-hour gastroenteritis caused usually by staph. But nevertheless, they were starting to drink and eat. So we did it. We made it. They lived. And that was scary. And by the way, one kid was 14, and his dad was not happy at all with the situation. Like, what on earth are you doing? And I don't blame him. So what was the source of the infection? Accidentally drinking river water, not cleaning the dishes well the day before, not washing hands before eating. Well, it could have been any of them, but we went and looked at the dishes from the night before, and they were filthy. So we were eating off of dirty dishes. That was the cause, clearly. Now, it could have been E. coli, enterotoxigenic E. coli from the water, or Campylobacter, birds poop in the water and animals defecate. It could have been those. But that wasn't it. It was the food. And so what steps should be taken to correct the problem of diarrhea and vomiting on a river trip on the Colorado? Make people wash their hands before eating, certainly. Wash dishes well in hot water, absolutely. Use bleach rinse on the dishes, absolutely, all three. And we just read everyone the riot act, and that has not happened since. And we get that water so hot, we put Clorox in it, we scrub it, and we let them dry in the sun, and we inspect them. I will never let that happen, and don't you follow my mistake. And I take blame for it. I mean, I wasn't washing the dishes, but my gosh, it was my trip, and we're trying to teach wilderness medicine down there, and people get sick and we have diarrhea. I mean, good heavens, what an interesting experience that we had. Good hygiene is essential. While a simple case of the stomach flu at home is miserable, it can become life-threatening in the backcountry. And so we survived that. Frank, were you on this trip with Lee Schussman? Were you on this? Right. Okay. This is the first one. This is when I met Frank and Lee Schussman. It was great. This was done with the wonderful Utah Academy of Family Physicians, such a great organization. And we called them and said, whatever money we make on this river trip, we'll donate to the UFP. And anyway, we took, this was a wife of one of the doctors from Vernal. So it's a 40-year-old female sitting on a raft in Cataract Canyon on a very hot June day. The water is very high and still in runoff. This is the beach where this happened. Now, Frank was there, Lee Schussman, and George Snell. Is George here, by the way? I haven't seen him in years. Does anybody know George Snell? Yeah. He was? Well, I wish he were here because he did this case, and I'd love to get his. But Frank was there, Lee Schussman, and I had graduated from med school 3 days before, so I didn't know what I was doing, but Frank and Lee and George did. And so anyway, this lady we stopped to scatter rapid. Anyway, she gets off the boat, and she becomes weak, and she collapses to the ground. This is a hot day. So now we have the wife of one of the doctors collapsed on the beach just above Big Drop 2 in Cataract Canyon, if you run that. Well, and I think Frank will tell you this, it was like a Chinese fire drill with all these doctors running around trying to solve this problem. Do you remember that? And finally, George just said, everybody go to that end of the beach, and we're going to treat this. And so we all dutifully went to the north end of the beach while they tried to figure out what's going on. She had no other major underlying problems. So what is the next step in the management of this patient? Put C-spine precautions on her, began evacuation. After the primary and secondary survey, begin assessment using AEIU tips. Now we teach that. This is where backcountry medicine, why someone is unconscious, is useful. And we add to allergies, if you remember this, allergies. In this, we put environmental, including hot and cold. Infection, overdose, underdose, trauma, insulin, meaning diabetes. But under trauma, we put toxic plants in there too. And then we put psych. My husband's wasn't showing me enough attention. And then finally, seizures. And you should memorize that. That's a good mnemonic for backcountry medicine. We make our medical students, and we have some of those here, fourth year, take this and memorize those. That's the answer. You always do the primary and secondary survey. Make the scene safe, and then unconscious, get AEIU tips. So what is her diagnosis? She's hyperthermic. It's a hot day. No cheating, Frank. She's scared, hysterical from the rapids. She's hypothermic from the cold water. She took too many of her medicines. She's having a seizure. I don't know if I put one more in here or not. So if I'll leave it at that because I don't want to spoil it. I think there may be one more. But from that list is the answer. Who votes she's hot? Bunch of hands. Who said she's hysterical? They were big rapids, so we were all a little nervous, actually. She's cold. He says cold. She took too many of her medicines. That's a good answer. She's having a seizure. Could have been. Oh, she's bleeding somewhere from trauma in the rapids. That's not the answer. I already told you. But we were being hit by logs. And I think Frank will tell you we had big boulders and things coming. Logs hitting us. So it could have been that. Well, it turned out she was freezing cold on a hot day in southern Utah. It was definitely hot, but I remember when we got off, we all just looked at each other. We were all just freezing cold because the water was hitting us, which was 47, 48 degrees, and the wind was blowing on us. We were all cold. And so we put that quickly into our differential. But it's an interesting case, and why I know Lee likes to tell this story, because here we were on a hot day and someone's hypothermic, freezing cold. And it took hours to warm her up. And that's what happened. So it made her even colder. Now, none of us had a hypothermic thermometer. None of us. Here we are, a bunch of physicians. I was a resident then, I guess, intern. None of us had a thermometer that would go below 96 degrees. So when you go in the back country, you need to get a hypothermic thermometer, a few dollars at REI, and that'll tell you. You put it in the rectum, and that's what the guide had. I think it was the Bowman had it, didn't he? And these guys were able to get the temperature and say she's hypothermic. You could diagnose it because you had the right instrument. So when you go back in the back country medicine, take a hypothermic thermometer that goes down to 90 degrees. It'll help you in saving a life. Interesting case. Well, then Paula the next day slipped and fell on some travertine and cut her scalp open. We had to suture, and she was a wonderful case for our first ever wilderness medicine course. She's never come back. And we charged her, too. That was what was interesting. No refund. Okay, so even in hot weather, it's possible to become hypothermic. Okay. We'll do two more cases, then we'll be done. We'll get that early. Two men, this is a great case because it tells you how good you are at diarrhea, backcountry diarrhea. Now, we've been here today, we studied hyponatremia, and we studied heart failure. Now we're going to talk about diarrhea. Two men in their 20s developed nausea, malaise after the first day of a river trip while floating down the Colorado River. By the end of the fourth day, they had diarrhea, severe abdominal cramping, and they had rectal pain. This was a year and a half ago. This case was reported. They've been very careful to make sure their dishes were clean and the food was fresh. So this isn't staphylococcal food poisoning like the other case. They're not vomiting. They don't have a fever. That's important in diarrhea. Now remember, there's two very important things in diarrhea: fever and blood. And that should be asked in every patient, particularly in backcountry medicine, because you can diagnose people if you have an answer to those questions about 90% of the time. Now, sometimes symptoms get confusing, but in this case, that will help. They probably drank untreated river water. Now, you have to think they don't have a fever and they don't have blood. So this is non-dysentery. If it's blood and fever, they have dysentery. And the differential changes. The treatment often is the same, but it may not be. Even though they tried, they did not clean their plates to prepare their food well. They became ill from contaminated food that was purchased at the store. Well, that's possible. Most illnesses that you get in the back country, you take with you. Well, there are illnesses out there, but most of them come when you bring them in. That's the truth. And you have to be careful. Well, they drank untreated river water on the first day. They were horsing around, as you do on a warm day on the Colorado River, and they just drank some river water. Well, birds poop and cows poop in that river. So that's a lovely thought. What are the likely pathogens? Enterotoxigenic E. coli, Campylobacter, Endomoeba histolytica, Giardia. Well, Giardia is way too short to be the case. Entomoeba histolytica just is not found in those waters. So it really has to be one of these two, enterotoxigenic E. coli or Campylobacter. There's some pretty pictures of those two. The most likely source of infection are cows, E. coli, and birds, Campylobacter. They're on our rivers. And be aware of that. Birds and animals poop in the river, as do humans, and you're likely to get E. coli and Campylobacter from those sources. The incubation time for Giardia is much longer. However, since they didn't have a fever and they didn't have blood in their stools, dysentery, which would be dysentery, a non-dysenteric pathogen must be the cause. So let's see who can remember their bacteria, their microbiology, which is dysentery, which is non-dysentery. E. coli is non-dysentery. Enterohemorrhagic E. coli, which, by the way, is a combination of when Shigella and enterotoxigenic E. coli got married and had children. We don't know when that happened. But enterohemorrhagic E. coli is genetically the same as Shigella and enterotoxigenic E. coli. So enterohemorrhagic E. coli is dysentery. But the common form, enterotoxigenic E. coli, is non-dysentery, where Campylobacter is dysentery. Now, last summer I was in Ethiopia, and that's the first thing you ask all the kids that come with diarrhea: do you have blood in your stools or not? And that tells you whether it's a worm or whether it's E. coli or something that they're taking. And it's a very important question. So enterotoxigenic E. coli is the likely source because they don't have a fever and they don't have bloody diarrhea. So what do you give them? They drank on the first day. They developed an infection. That's within the time frame, 1 to 3 days, and they gave them Cipro. And within the first dose of Cipro, in 2 to 3 hours, they were feeling better, and by the end of the trip, they were cured. Cipro should be in your first aid kit. Erythromycin is also good because that's better for Campylobacter. But Cipro is good for for Campylobacter too. Cipro is a very good antibiotic because it covers most everything that the GI have, and it can do typhoid fever, and we go through a lot more of this, but this is such a good case. Take appropriate antibiotics and no common pathogens that you get in the backcountry. And if you don't carry, you can carry our manual or you can go get Auerbach's book out of Stanford. Okay, now this is the last case we'll do. This case was reported to me last summer. This happened in August. This is a very interesting story. It happened on the Green River over on the Gates of Lodore. No. Desolation Gray, I beg your pardon. I just had this case reported to me, and one of our senior medical students this year actually participated in it. So let's go through it, see if we can get it. It'll be our last one. A 40-year-old female is rafting on the Green River in Utah. And isn't that a pretty river where they go down in there? It's July. It's July, not August. Over 100 degrees. On the first day, people noted that she was somewhat lethargic and did not look well. So right from the get-go, she's sick. Everyone was encouraged to drink water and stay cool because it's hot. By the evening of day 3, she was found laying, is that right, or lying? In her tent, sweating profusely. She was found lying. I think it's lying in her tent. She was led to the river to cool off. So they take this woman, 40-year-old, down to the river, throw water on her and leave her there to get cool, assuming that she's nauseated because she's hyperthermic. At the river, she threw up, and then they saw her crawling back into her tent. She couldn't even walk. She crawled on all fours back to the tent. Now, that's lovely. Now, there's not a single physician, PA, nurse, dentist, podiatrist, EMT, nobody with any medical training is on this trip. They just see this woman. It's sort of a conglomerate of people. And this poor woman is now on her hands and knees crawling to her tent. Not good. About 1 hour later, she began to have seizures. Oh, good heavens. That is not a good thing. What is the next step in the management of this patient? Begin evacuation. Get help. It's always a good thing. Pour cool water on her. She's hypothermic and dehydrated. And begin evacuation. See if someone has anti-seizure medicines and try to give her some orally. Now, there you are. What do? Now, most of you in here have some medical background. We have all kinds in here. And they're going to come to you because you look like you know what you're doing. Now, what would you do here? This is an actual case. They flew her, ultimately, to the University of Utah, so we know exactly what happened, precisely what this was. But it was reported to me before I knew that. Well, what they did is these people said, we have no idea what's going on. They had a sat phone, and they called, And as a helicopter came in from the University of Utah, they couldn't land because they thought it was too windy, even though there was no wind on the ground. Up in the air there was. So they couldn't land. This woman seized all night long. Now imagine her husband and the people just watching her seize all night. They came in at the crack of dawn and flew her up to the U of U medical school, medical center. Why was she unconscious and seizing? Okay, so you got her out. That's the answer to that. You know, you could pour water on her, try and seize your medicine. You know, it's not going to hurt her. But the point is, there's nothing you can do in this situation. And if you have a sat phone, she's got to get out. So let's see how good you remember on AEIU tips. A is allergies and altitude, we add to it. E, epilepsy and environmental, meaning hot, cold. I, infection. O, overdose of drugs, meds, alcohol. U, underdose of drugs. I mean, she may have a seizure disorder and didn't take her medicines, or she's, you know, whatever. So you can get underdosed. Trauma, toxins, we add to that, plant and animal. Insulin for diabetes, psych, conversion disorders, and so on. And finally, a stroke. Now, she's not entirely unconscious, but this is the mnemonic that will kind of point you in the direction. So think about it for a minute. She's sitting there seizing. You've got a sat phone. You know when you're coming in the morning. You're out there on the Green River, and you've got a 40-year-old who you met 3 days before, never looked really healthy, seizing on you. What do you think the cause is? Husband says, no, she's not had a seizure disorder. She's healthy as could be. She's not fallen. Everyone else looks fine. Backcountry medicine, it's hot. She's been drinking water. I heard the word hypervolemic, hyponatremic. Who thinks it's low salt? Sounds like it could be low sodium. It's not stroke. It's not psych. She's not a diabetic. No trauma. We didn't hear of toxins. Underdose of medicine is not likely. Overdose? Could it be an overdose of medicines? She could be withdrawing. That's a very good answer. I've not heard that one. Whoever said that, you get an A in the course. She could be infected in epilepsy environment, and in the case she could be hyponatremic. Well, this is what it ended up being. She's an overdose of drugs, and you would never have known. Let's talk about it. After seizing all night long, she was evacuated by helicopter to the University of Utah Medical Center. One of our senior students, when he was a third-year student, actually took care of her. And so I got the absolute details on this. Before it wasn't. I was told that her sodium level was, in fact, dangerously low. In fact, the man that called me to tell me about this case said that her sodium was 0. Well, so we say dangerously low. I can give you the number now. The number was 121. That's what the senior student told us. That's low. I've seen lower, but that's low. And so she had a sodium in the low 120s, and a CT scan of the brain revealed severe cerebral edema. But wait a minute, I said it was an overdose of drugs, but I just now said it's hyponatremia. What's going on? So the brain is swollen. They raised her sodium, and she recovered. So now you get down to business. And the students and the residents go in and say, what is going on here? You know, they're from New York. Now listen, that's an interesting question. She was not on Diamox, but who said that? It's like playing Where's Waldo up here. So keep going. She wasn't altitude. Very good, very, very good though. You're on the right track. So she's taking something. What's she taking? She could be taking a diuretic, but that wasn't it. That's this is right, and I'm so happy that we're thinking beyond just drinking water to cause her hyponatremia, because that would be the obvious answer. You know, drink water, drink water. Remember, she looked sick from the beginning, so she wasn't a well lady to begin with. Well, they asked her, "What are you taking?" Finally, she wakes up. She stated she began to take 12 different herbal medicines several weeks before the trip, in order to cleanse her body. I have no idea. The resident couldn't remember. The student. We have no idea. So she's out there just loading with medicines to cleanse her body, she said. Her illness was already well underway prior to the trip, hence her ill-looking appearance at the start of the trip. She had not ingested more water than any others. So it was felt that the herbal medicines played a role in her low sodium, and in fact, He couldn't remember, but they looked them up and actually found some that are known to cause hyponatremia if you're not careful. The patient was not dehydrated or hyperthermic, as seemed to be the obvious case. Her sodium was, in fact, low. It's possible to have too much water on a hot day. Not likely. And I know some of those sports journals published an article warning people a few years ago, darn it, you're going to drink too much water out there and you're going to become hyponatremic. Well, that's 1 in 100,000. You drink water in the backcountry. There's no reason. Watch your urine. If it gets so clear, then you can pull back on it. But I never have seen someone in a hot trip that is hyponatremic because they're overhydrated. I've seen the opposite. So it's possible, and I'm going to emphasize, possible to have too much water on a hot day. And while unlikely, the cause might be related to the ingestion of another drug or substance rather than drinking too much water. Okay, that's it. Thank you all very much, and I hope to see you in one of our courses.